Thank you all. Everybody take a seat, please. We're going to go ahead and get these hearings started. I would like to thank everybody for coming by today for the joint Senate and House Medicaid committee hearings. We had 2 good days of hearings a couple of weeks ago, and we look forward to another couple of good days for having input from providers. Chairman Blackwell will be with us in just a second, but since we're on such a strict time schedule and to try to get everybody in and out, we're going to go ahead and get started. I'd like to thank all the House and Senate committee members that got here. I would like to thank the Senate staff and the House staff for what they've done in putting this event together. And our first speaker today is going to be from the Mississippi Hospital Association, and it's Tim Moore.
Chairman Hood, thank you. To start off, the pleasure of going first is to have the opportunity to share our appreciation for you, Chairman Blackwell, and other members of the committee to actually hold these hearings and listen to providers. So we hope that we're able to provide information that will be helpful in going forward in the upcoming session. I want to start out with just one more shout out. And of course, Drew Snyder is here. And I just wanted to say thank you to Drew and to his staff. Had an opportunity to do that the other day on a call with a lot of folks on it. But I think it's important that this committee knows that the Division of Medicaid has been entirely different to work with under his administration, and we just want to say thank you. And we appreciate that, Drew. Moving forward, in our little presentation here, as you'll see from the agenda, Richard Robinson was going to join us today, and ironically enough, Richard was going to do most of the talking, because in most cases, lawyers like to talk more than I do. So Richard actually grew ill about an hour ago, and we are hoping that that's not a COVID situation, but he had some unique symptoms without fever, so he sends his regrets. He would love to be here today and has done a great job compiling information for this committee to review. Starting off here simply, just to remind you what the hospitals are. They employ over 58,000 individuals, connected to almost 120,000 jobs, direct salaries and wages over $8 billion in the industry. Mississippi hospitals provided approximately $616 million worth of uncompensated care in 2019. Key word there is cost. Many people get caught up in charges. This is not charges. These are costs off of the cost reports that our hospitals file. So it is direct cost to those hospitals. And then in the upcoming year, we estimate, and that being we, MHA estimates, that about 2/3 of the state share will be provided by hospitals through the assessment that funds the state match, okay? And that being the state match that funds hospitals. Chairman Black will talk to us about talking. He said he wanted to hear the good and wanted to hear the bad. So that's what we're going to do. We want to start out and talk a little bit about the good and things that have happened over the last year or so that have been very productive for hospitals and for the state of Mississippi. The first one is, let's talk a little bit about 2018 session, and then, of course, the passage of Senate Bill 2836. In our opinion, from a hospital perspective, from a provider perspective, probably one of the best pieces of legislation, most comprehensive piece of legislation that has been passed for hospitals in a long time. And we are appreciative of that, very appreciative. Nothing that I say going forward is to take away from that, because we are very appreciative of that. The 5% reduction for hospital outpatient payments was one of those things that was key. The flexibility of supplemental payment model was included in that. It eliminated the cap on physician visits. It removed the cap on prescription drugs. It increased reimbursement to OBGYNs to 100% of the Medicare rate. Required certain psychiatric services to be reimbursed at 100% of Medicare. Expanded Medicaid waiver options for opioid and other highly addictive disorders. Maintained that MCOs have to pay at least what Medicaid would pay for services rendered. It's very, very important in our program. And it maintained the stability of reimbursement for FQHCs. So you see, it was a very comprehensive bill. It was not just hospitals. It touched a lot of people. And certainly there's members on this committee that actually attended meetings prior to the session that this group of providers that provide services for Medicaid recipients came together and talked about the issues that they were having. And they consolidated those thoughts and brought them forth to the legislature. So there was nobody running around behind somebody else saying, well, we want this. No, they don't need that. You need to do this. It eliminated all that. So you guys knew there was a good, comprehensive piece of legislation that you could feel comfortable supporting, and we appreciate that very much. However, there are a few things, when we talk about the bad, there are a few things that were included in that bill that have not been implemented. And that's, it's out there. It just needs to be looked at again. Cost reimbursement option of 101% for our critical access hospitals to follow similar reimbursement that the federal government uses. Authority for MCOs to develop alternate payment methodologies to incentivize value, improve health care quality and outcomes. It's in the bill. Standardized credentialing process. This is still an issue that we face on a daily basis with our hospitals. MCOs are required to share data with providers. That's very limited in where it's happening. Annual audits are required of MCOs to determine the financial benefit of the MCOs, the difference between premiums paid to MCOs versus payments made to providers, compliance with contract performance measures, and where the costs have been contained due to improved health care outcomes. Then we get to the ugly. Through 2019, Mississippi paid MCOs $1.6 billion in premiums, more in premiums than paid to providers for medical payments. For calendar year 2019, the MCOs made almost $300 million in administrative fees, while your hospitals absorbed $616 million worth of uncompensated care. That seems to be somewhat of an unbalance. MHA estimates that current outstanding past due payments to hospitals within 30 days and more, is between $10 and $20 million across the state of Mississippi. Payments owed to hospitals. No independent audits as required by state law. No improvement in health outcomes. Hospitals being required to hold patients in observation status before the patient can be fully admitted. Ongoing coding issues with edits and procedure codes. Ongoing issues loading correct and timely provider identification numbers. Hassles with prior authorizations. These are issues that are not new to the year. They have been ongoing over the years. And I think many of these you may have heard earlier. Going on with the ugly. $750 million for state fiscal year 2011 direct state appropriation for Medicaid. And that was a little over 700,000 individuals in the Medicaid program at that time. Jump to 2020, the state appropriations reached $931 million, which now we know that that would be higher if it were not for an increased FMAP, which we're very thankful for from the federal government. But now we're looking at an increase in Medicaid recipients to 721,000. Some of that, I'm sure, is due to our COVID situation, our unemployment rate, and things that we're having to deal with as a result of that. Fiscal year 2015 to 18, the per member, per month growth for Mississippi Medicaid has exceeded our neighboring states. I think that's a very important thing for us to look at. When you compare our per member, per month growth to Alabama and Arkansas, Mississippi is at 15%, Alabama is grown 2%, and Arkansas 4%. We've been very limited on our savings from our managed care companies. 1% withhold on MCOs cap payments based on the HEDIS scores places approximately $26 million at risk in the MCOs, in addition to $1.5 million liquidated damages since 2018. And if the HEDIS scores are the health effectiveness data and information set, which are used to look at the quality of care that is provided. On the next slide, you will see this is penalties that were actually enforced by the Division of Medicaid since the end of, since 18 through this year so far, through October. You'll see it's gotten much more aggressive over the 19. You only see one for 18. It's gotten much more aggressive, and we appreciate the Division of Medicaid enforcing those requirements. We talked about quality. The importance of moving forward, with the Medicaid program was quality. We've not seen a big improvement in quality as we've moved through this program. If you look at the numbers all the way back from 2015 through 2019 to now, we pretty much peaked at 2 on a scale of 1 to 5, and it stayed very consistent, both with Magnolia and with United Healthcare. Very consistent. If you move on and you start looking at where we are from a business standpoint, I mentioned the dollars that were going to our managed care companies over the last few years, and of course the uncompensated care that our hospitals are absorbing. And you can look at the stock price that is on these two companies. We just did the two. Significant incomes increases there. Centene's up 86% since 2015, and then of course United is up 149%. Now, something that we could consider is the possibility of looking at our managed care companies to help us with the state retirement program. Looks like if we had invested in there, we would have done very well in that part. So there's a role to play there. Hospitals are working to improve quality. Let's talk a little bit about that. Over the last year, hospitals have worked with the Division of Medicaid and has put money at risk with the hospitals based on quality. If we look at, I'm sorry, trying to keep up with the clicker there, $215 million in hospital supplemental payments are conditioned upon satisfying Medicaid quality measures. And do remember now that hospital assessments actually provide the drawdown for that money, the state match for that money. It's split up into equal portions. $107.6 million is based on improving outcomes. So there's quality measures, participating in a HIN, health information network that will record quality outcomes and be able to really move the needle on quality and moving forward. Then also the other 107 is contingent on preventing avoidable readmissions to the hospital. And this is part of the Medicaid's managed care program quality improvement strategy. It does not include anything from the managed care companies. This is Medicaid and hospitals working together to try to improve the health care of people in Mississippi. Recommendations on the upcoming bill. The Medicaid bill certainly is always important, as it historically has come up every 3 years. There's 3 points that I will raise to keep in your mind. It makes it very easy. If you think of CAP, credentialing, appeals, and payment. And we're going to talk about those a little bit right now. But if you remember CAP, you will know what we are talking about from the Medicaid Technical Amendments Bill in 2021. Recommendations for the Medicaid bill: provide health care coverage for low-income working adults, extend eligibility for pregnant women, expedite Medicaid appeals process. That's one approach to move toward. Now, if the legislature chooses to reauthorize the managed care companies, there's certain things that need to happen there to shore that up for our providers. Standardize and expedite credentialing and clinical guidelines. Require the MCOs to pay no less than Medicaid rate. If you're going to pay less than Medicaid rate, there's really no need for managed care companies. Medicaid can pay less. There's no reason to do that. And the administrative costs continue to be where they are. To the extent, and this is important, to the extent of law, because we do realize there are certain federal guidelines that would limit this. But if you start looking at reduction in payments, you should fully exercise reductions in MCO administrative costs before going to providers that are trying to take care of our citizens and our low-income individuals in the state of Mississippi. That is certainly an approach we need to look closely to. Require that one of the MCOs be a nonprofit provider-sponsored health plan as identified by Mississippi law to demonstrate how effective such a model can be. There should be an opportunity to look at something different. We've continued to do the same thing over and over, and we just showed national quality scores. We've not seen a change. We've not seen an improvement, although we continue to see costs go up. The reason to go after that. Now, I'll close with this and then certainly be available for questions, but the simple choice. Are we going to continue to turn our backs on a plan which would generate hundreds of millions of dollars of straight revenue, would help hundreds of thousands of Mississippians, of low-income working adults, and the Mississippi hospitals and healthcare providers who serve all of us? Or are we going to subsidize a corporate welfare program for for-profit, out-of-state managed care companies which have spent the last decade taking billions of dollars out of state and adding administrative costs to Mississippi providers and not moving the needle at all to improve care of Mississippians? Mr. Chairman, I'll be glad to take questions.
Senator Wiggins, you're recognized.
Thank you, Mr. Chairman, and thank you, Tim. Just a comment. I appreciate your comments, and I notice I don't see any press here, but I think it should be noted, since we've had the hearings and the different speakers, that a consistent theme has been that the Medicaid program in Mississippi is working certainly better than it was 4 years ago, and that's thanks to the Division of Medicaid, that thanks to, like you said, a bunch of all the stakeholders having a meeting, so I appreciate that.
Thank you.
It'd be nice if the press actually covered that, because it takes
We've
all
actually
of us.
tried to say that several times so that they do know that. So
Yeah.
It is.
So I have a specific question and a general question. So I continually get from different, certainly one hospital, but from multiple hospitals, about the inequitable distribution of the DISH payments under the formula that is done and that is laid out in the tech bill. And for the benefit of the committee members, that's the DISH funding that comes from the feds, and it goes to the hospitals. And I personally get comments that say it is inequitable to how it gets distributed. And in essence, there are certain hospitals in this state that honestly get more than their fair share, and there's hospitals in this state that get less than what they're entitled to. So what do you propose to how to fix that inequity? And let me say that just saying that the Hospital Association is going to have a committee to come up with that, that's what would happen last time, and we're still 4 years here and it's still inequitable.
Well, that's a good question. I think we probably have to look at it on the grounds of what is inequitable. We are talking about one pie, one set of numbers, and if when you move money, it's going to move somebody else's, and somebody else is going to be inequitable. Now, the Hospital Association has had a committee together working with Medicaid over the last year to develop some changes to the model that hopefully will address some of the inequities. The component that is being looked at now is actually the tax model. The way the tax is generated are beds the right way to go? We have done some preliminary work.
Just to interrupt, I'm sorry, one of the things I've heard is that the current formula rewards, it doesn't reward savings, it rewards continual expenses. That's what I've heard, and it seems to me like the formula should reward those hospitals who are given better care at a lower cost.
I agree with that.
Okay.
I agree with that. I think finding that is very, very difficult because of all the variables that go into this. And we've got some folks here that are much, much more equipped to discuss the model than I am. Matter of fact, if Richard was here, he could help you with that much, much more than I could. But it is a difficult model to address because when you start looking at all the disparity of hospitals that we have across the state of Mississippi, they each, in sections, are handled differently. So it creates, but however you handle them affects another segment of those hospitals. So finding the perfect way to do it looks like is a quest for eternity, but we are continuing to try to do that and have all of those hospitals, both those that feel like that it is inequitable and those that are okay with it at the table.
Well, if
And
y'all could assist on that, because I think this is the time to do that.
everything we can.
Then my other general question is, the thing that stood out on your slide is from 2011 to 20, direct state appropriation grew 24%, and then the total Medicaid and CHIP enrollment only grew 2%. So I guess that's the question that comes down to is, how is a direct state appropriation, how is that sustainable if the growth is only 2% of beneficiaries and enrollees, and yet we've done everything we can, or certainly think we have, to try to control for costs, and yet it's grown 24%. I mean, is that not the problem? Seems to me that's the problem that we, the legislature, is facing, particularly in appropriations, is that with only 2% growth, we're appropriating 24% more in appropriations.
Yes. And over, what was your timeline again? Over what period?
Well, it's on your
Are
slide.
you using these?
From 2000, it's your slide.
Which slide are you on, son?
I'm looking at the one and the ugly.
Three. Page 3.
From 2000 FY11 to FY20, direct state appropriation has grown 24%. From FY11 to FY20, total Medicaid and CHIP enrollment has grown 2%. So with only 2% growth, we, the state, have obligated 24% more in appropriations, and when you multiply that into Medicaid, that's billions of dollars.
Yes, it is. And my apology, that is, that I overlooked that slide because that is
I
not
know, I think
actually-
you said it.
Yeah, it's not on my,
Number 3 slide.
Is it page 3 or number
can we go
slide?
back? There we go.
Okay, go next. Oh, y'all took that out of your little presentation there.
You mentioned it. It's on page 3. It's the bottom slide on page
That's
3.
okay. I will, and I apologize. I will find out and I will get you an answer there. That's, don't know exactly how that, got
But you're not
changed.
saying those numbers are wrong, are you?
No, no.
Okay. There it is right there. It's
you go.
number 6 on yours.
Just had to find the right slide.
Okay.
Good deal. Okay, now you're looking at, from 2011 until 2020, it grew 24%. So the appropriation has grown because of the enormous number of, the numbers have grown way up as far as the participants. We have
No,
much
right
lower
below
numbers.
that, you say enrollment has grown by 2%. So with a 2%,
Enrollment in CHIPS. Oh, and Medicaid, I apologize, yeah, okay. Well, that is your cost. I mean, let's look at how much of that is the managed care company. We just talked about the billions of dollars that had been gone out of the state, hundreds of millions of dollars each year that are going out. And you start looking at the difference in that and the payment to your hospitals, and it's not, the improvement is not the
but
same.
that,
But it is a problem that's the
but
center.
that is not just the managed care companies, if at all. I mean, that's increase in costs of medical, that's increased
All of
costs
it,
to
yeah.
hospitals and all of that.
That's correct. But they pay claims on all of it. The dollars are going out. You need to look at where the dollars are going. You know, when you looked at your premiums were more than you
So
paid out.
are you saying that if there were no managed care companies, that discrepancy or whatever you call it wouldn't exist?
I'm saying that if our plan was run like Alabama's plan, they've only gone up 2%, where we went up 15.
With a 2%
It's
increase
no,
in
there's no
enrollment?
managed care in Alabama.
Okay. I mean, I appreciate you saying that. I don't know that the numbers bear that out, even based on the managed care commission that was done and all of that, but I think that's the kind of stuff that is important. So thank you.
Sure.
Representative Hines, you're recognized.
Thank you. The $300 million in administrative fee, that's just for 2019, correct?
That's correct.
So how much have they made over the last term of the contract, do you know?
Oh, goodness.
Is the 300 million an average, or if
It's actually gone up as the years have gone on,
okay.
looking at billions.
And so what is, you have $616 million uncompensated care. So who totes that note? The hospitals or the
Hospitals.
counties or what?
The hospitals actually absorb that.
Okay. And is there any refund or rebate from the managed care companies back to the hospitals who provide that uncompensated care?
No, sir. There is, and as time has gone on, early on in our world of healthcare, the federal government reimbursed it 100%, and it's continued to come down and down and down and down to where that's not, it's not there anymore.
So it looks like that if we were to draw some of those administrative costs back, we could make some of those rural hospitals whole.
Yes, sir. It would help.
Okay. One last question. The gentleman from the coast asked you a question about the percentage of the increase, and I'm a little curious about that too. Has the cost of health care increased?
The reimbursement for healthcare has not increased that much.
Okay.
So the numbers are lower there. Certainly, as supplies have gone up, salaries have gone up, the ability to find staff, physician salaries have gone up, but the payments have been very consistent over the last few years from Medicaid.
So if I'm a CEO of a hospital in a rural area and I don't have a heart surgeon in my area, and then I start to recruit one, and he realized he'll be the only one in my area, and his normal salary might be $160,000 a year, and he said, "Well, I'll come, but you got to pay me $220 because I'm the only guy you got." That increases the cost of care in that region. Is that correct?
That is correct.
Which would then drive up the numbers for Medicaid. Is that correct?
It would drive up the cost that
Right.
hospitals absorb, but it does not increase the payment from Medicaid.
Okay. All right. Thank you.
Yes, sir.
Representative Curry, you're recognized.
Thank you, Mr. Chairman. So I want to go to the owing of the hospitals, $10 to $20 million. So do you have a list of where that mainly is, or can you help me with that?
I can. I can give you the top three. Tupelo, North Mississippi Medical Center and Health System was at $5 million. Baptist Health System was at $7 million. Forest General was at $2 million. And the remainder of that was made up of several hospitals put together.
So my job in home health, I visit a lot of hospital CEOs, and that's their number one complaint. When I want to talk about home health, they want to talk to me about how much MCOs owe them and what a process it is. And most of these are very small hospitals. We've lost some, they've closed, and with them not being able to get paid, I think Aberdeen was the last hospital that I went to, said that United owed them $1 million, a little hospital that doesn't have the means to get it back. Right. And so what I'm worried about is more hospitals closing, because we have no way of getting this money back. So you call, you get a PA number, you take care of the patient, and you do a great job, and then you don't get paid. It's just, I don't understand, after you get that PA, then you've got to go through a year or more of an appeals process. I don't know if we've expressed enough to people how hard that appeals process is. It's expensive, and you're sitting in there waiting on money to pay your doctor, to pay your nurse, your janitors, everybody. So, when we want to whine a lot about rural hospitals closing, but we don't want to take a hard look at why. So I know of many smaller hospitals. Those are big hospitals, and I'm sure one day they'll be able to get theirs, which is ridiculous that we put them through this, but there's a lot of rural hospitals out there suffering because of MCOs. So when you said something about hospitals and Medicaid meeting to prevent readmissions, which is a real big deal in our world of healthcare now, readmissions. And you're saying that the MCOs are not at the table. You're at the table, Medicaid's at the table. Where are they?
That would be through Medicaid. They would work through Medicaid.
Were they invited?
No, not from our standpoint.
You're shaking your head yes. So they weren't at the meeting, they were invited? That's really what I'm looking for here. So we go back to the same thing as we talked about in the other meetings. We pay managed care to manage patients, yet we've never seen that actually happen. Am I correct?
Yeah.
Or?
Yes, ma'am.
Okay.
Now, I will say in that, we're talking about the good, the bad, and the ugly, and what we've done. In working with the MHAP money that we always strive to preserve for hospitals. Well, CMS has said, okay, some of this has got to be at risk for quality. So that really is more focused toward hospitals and Medicaid. So
okay.
I don't want to really give
okay.
anybody a black eye that doesn't deserve it on that one. Yeah.
I'll give them that one then.
Okay.
So, and I'm confused about the numbers as well. Every meeting that I've been to on appropriation for the last several years, numbers of Medicaid recipients has gone down. Can you shake yes or no? Okay, so I think the cost keeps going up, recipient number keeps going down, and that should be something to look at. That's, so I don't even know. I guess the 2% is CHIPS on here that went up because it was not Medicaid recipients. Well, I don't know if you can speak. I mean, I'm good with it, but. Go ahead. So one more question, I'm done. On page 4, and it's this little funny chart that you can barely see without your
Right.
glasses. So is that, well, and that is what Medicaid has charged MCOs for fines?
That's
Is
the
that an
penalties
easier
that
way
have
to
been
put it?
assessed for those, correct.
Which I'm proud to see, they used to
Yeah,
not,
absolutely.
under Jellic, do it at all. So these are pretty good fines. And so they just rather pay the fines and pay the providers?
I'll have to,
I
you know,
guess,
that would be.
I mean, I'm just assuming that's okay with them. They make enough money, they can do that. Thank you.
Representative Yancey, you're recognized.
Mr. Moore, thank you for being here today.
Sir.
$616 million in uncompensated care in 2019. That's a big pill to swallow, is it not?
Yes, sir, it is.
The cost to expand Medicaid in Mississippi, the federal government would cover 90% of that, is that correct?
That is correct.
And 10% would be covered by the state. How much would that 10% come to, would you estimate?
It would, of course, depend on the number of enrollees into that plan. You know, we've looked at it if there were, and then, of course, the variables that come into play there is how much would the premium cost be for the year. And the numbers we've used has been $5,000 a year with Acton. We looked at the state plan. We've looked at other states that have done expansion models in their states, and that's pretty consistent with what we've seen. If you did that, and then you looked at, let's just say you had 100,000, or let's say 200,000, be easy math. If you had 200,000, 500,000, you've got $1 billion of premium there. So 10% of that would be $100 million for the state, and you would get the $900 million from the federal government subsidize that, which we've offered to pay for.
It seemed, now I was going to ask you that. It seems to me when I was here in the legislature the first time that there was a similar situation where Governor Barber struck a deal with the Hospital Association, and Hospital Association had an assessment, and they put that up and drew down the money from the federal government. So you're saying the Hospital Association again, or the hospitals would be willing to come up with that 10%?
Yes, sir. That
Each
is
year.
correct. And if I might add to that just a little bit, the difference in where we are today and where we were then is there were no managed care companies. And when that assessment was agreed upon, all that money, of course, it went up, it was matched, it came back, and it paid claims to the hospitals. So the money they put in, basically they got back. If you look at it now, there's an enormous amount of administrative cost that's going into that. And now all those dollars are not coming back to the hospitals that they're putting up. It's going to basically pay the administrative cost of somebody that doesn't want to pay you.
All right.
Makes it a challenge. Just
Thank you very much.
thank you, sir.
Senator Polk, you're recognized.
Thank you, Mr. Chairman. I have a question about investment advice. Have you called PERS and offered them any investment advice that they should have invested in MCOs 5 years ago and we wouldn't be having a PERS problem?
I should have. I should have called. I wished I had. I wished I had invested that way.
Representative Robertson, you're recognized.
Thank you, Tim. I appreciate you being here today. Do y'all have any idea of what your administrative costs are and what, if they're more or less than national average? And if you do have a cost, what should they be? I mean, administrative costs for me in my business, that really detracts from my bottom line. I'm wondering if that's been a substantial part of where some of this money's been sunk into.
We absolutely agree with that. We think that's exactly what it is. Now, when you're talking about administrative costs, you mean it's administrative costs coming through the plans?
Correct.
Yes, and I am sure they are. I'm sure they're benchmarks, and we'll be happy to research that. One of the things that we really are looking at now is the increased administrative costs that has been created for hospitals and all of the denials and the processes that have to be done, whether you're using 3 different ways to code the same procedure, whether it's Milliman or one of the other sources, they're all different, and you have to, as a hospital, subscribe to all of them, and it just makes it more complicated. So there is a cost increase administratively to hospitals to have the managed care company as well. So,
Do you think that if there was a standardization of that process, would there be savings on both sides, potentially for the managed care as well as the hospitals?
I do think so. Definitely on the hospital side, and I don't know how it could not be. It may cut into profits on the other side because it'll be much harder to deny claims and to prolong the process. If you're all doing the same thing, it should run pretty smooth.
I'm going to recognize two more members, and we're going to move along. We have some other presenters that are coming. Representative Hines and Representative Scott.
Thank you. Quick question. It's been brought to my attention that a hospital loses more money seeing Medicaid patients than treating uncompensated care patients. Is that true? The Medicaid, you lose more on your reimbursements back from the managed care companies than you do on your outright losses on uncompensated care.
I would have to look into that. I'm just trying to think from a logical standpoint. I don't see how that would happen. Simply because if you're getting paid anything on a patient, it's more than an uncompensated care patient because you're not getting anything.
Well, that's why I'm asking you this now.
Yeah,
Okay.
I'll be glad to look into that and
Okay.
see if you can share with me where that's coming from. I'd be glad to know exactly what it is. And
Will
try
do.
to look into that.
Okay.
Be happy to do that.
Understanding though, whenever you don't get paid, you've already spent all this money.
Representative Scott, you're recognized. You mind stepping up to the microphone, Ms. Scott, where everybody can hear you?
I wanted to ask you, sir, at the beginning of your sheet, you say that Medicaid expansion could reduce the burden of your uncompensated care by 50%. And I heard you explain to Representative Yancey that what it would cost for Medicaid expansion. Now, I just want to be clear. It was my understanding that under the Trump administration, that the funding source for Medicaid expansion had changed, had been terminated, that was not available to states. So are you saying that it is still available to states, that they can get, that Mississippi could get that 90% start-up dollars?
Yes, ma'am. And the way we are approaching it is not through the ACA, but yet through a 1115 waiver.
Through a waiver?
Yes, ma'am, through a waiver option, similar to what Indiana did.
Similar to whom?
Indiana did the same model when now Vice President Pence was in Indiana. They actually modified their plan. They already had a waiver in place, and they got approval from CMS to actually change that waiver to get the same benefits of the ACA, or many of the same benefits, with certain requirements. And that's what we've talked about, is how we could approach it. So if, let's say the court, which I doubt very seriously, if the court comes back and were to overthrow the ACA and rule it unconstitutional, Indiana will not be affected. They're under a waiver. So we would be secure for, typically waivers are 5 years, so we know we would have it for that length of time.
Okay, so I want to be clear. When Vice President Pence was governor of Indiana, he did not expand his Medicaid program under the regular AC, Obamacare. He elected to go through a waiver. When Louisiana was, when the Republican Senate terminated those dollars and the court found the mandate unconstitutional, and it changed how states could be refunded, Louisiana was given a different set of circumstances by President Obama, and that's how they got in to expand their Medicaid program. That's correct, right?
They did pretty much an
But that
ACA
is correct.
model.
That is what happened, right?
Yes.
Okay, so now, what you're saying to us is that Because, you know, there has been a good bit of interest in Medicaid expansion by some of the people here. So what you're saying to us is that if at some point the Obamacare program is struck down as we know it, then you're going to develop some kind of demonstration and ask for a waiver to put Obamacare in place in Mississippi and ask CMS to then give us a special dispensation for the funding, right?
That's how we would implement it. Yes, ma'am.
Okay. All right. Now let me ask you this. You had in your handout this thing about uncompensated care, and we had 2 or 3 questions about it. Can you explain to me what uncompensated care actually means? Did you do $616 million worth of care that you didn't get paid for? Or was that some of where the insurance companies and you all decide that you're going to allow for a certain amount of payment and that's going to be what's acceptable for the full pay? Can you explain that to the committee? Because
Yes, ma'am.
sometimes we get a little confused and we think that that you guys have actually lost that much money when you haven't really lost that much money.
Yes, and this actually, the uncompensated care number that I'm sharing with the committee has absolutely nothing to do with charges or payments. It is strictly, hospitals for many, many years have had to file cost reports with everything they do is nailed down to a cost, and that's reported to CMS. Utilizing the cost reports, we were able to calculate over 2019 that the actual cost incurred for caring for uncompensated care patients was $616 million to cost to the hospitals. Now, that may entail a patient that you receive absolutely nothing from. They cannot pay or will not pay, whatever the reason, whatever it is. And then there may be some where there are some copays or deductibles or something like that are not collectible. And that'll be a much, much smaller piece of that number. But that is also included in an uncompensated number. It is no payment for the expected. But now, let me reiterate now, that's how those patients are identified, but the actual number that you have is cost to provide care. I think that's really, really important for folks to know that. Charges would be, as you know, much, much greater than that.
And so in this number, so that we can kind of understand what you're saying, this would be Medicare patients, this would be regular insurance patients that, you know, that there was an agreement upon. So this is not just $616 million of uncompensated care for the Medicaid population, right?
No, ma'am, this is for the entire population.
This is for the entire population, okay.
Yes, ma'am.
Now, my last question to you is, because we've been talking about money, and I kind of want to talk a little bit about the people. You have here that there are no improvement in health outcomes as it relates to this managing of care and the patient population by the MCOs. If we were to compare health outcomes to people who have regular insurance, would that not be the same statement that you, now I'm not taking up for them, but I'm just saying, wouldn't that be the same statement that in Mississippi we have poor health outcomes, whether you're insured or uninsured? We can make that broad statement that we have poor health outcomes?
No, ma'am, I wouldn't be able to agree with that statement. I think whether we want to admit it or not, we have healthcare inequities in our state, and we have populations that for whatever reason don't respond the same way to healthcare. I think our insured population, our numbers would be much, much greater than that. The quality indicators would be much greater than what you're seeing on this population.
Okay, and I agree with you, and I'm glad that you said that, because that's important for the committee to go understand as we move forward, that, and we had some legislation, Hines can tell you, that was talking about improving health outcomes, particularly in certain populations. Then the hospital is being required to hold patients in observation. Who is requiring that and why before a patient can be fully admitted?
Yes,
Who's
ma'am.
requiring that, and why are the hospitals adhering to that kind of policy?
That, we had hospitals that reported to us over the last few weeks, they had received letters from the managed care companies saying that no longer would they pay for inpatient services without a period of observation. That is going to create all kind of issues on the payment side.
So if I come in having a heart attack, you got to observe me first? Is that what you're telling me?
Ma'am, say that again?
If we come in having a heart attack, the managed care organization saying that you have to observe me to see how serious, critically ill I am before they're going to do anything? Before your hospital emergency room can do anything?
We can certainly share a copy of the letter with you
Please
that
do.
would state that
We won't see that.
be
All of us need a
no
copy.
inpatient
Okay.
without an observation period.
Thank you so much.
Yes, ma'am.
Thank you so much, Tim. And if members have any other questions for Tim, if you'll stick around until we get finished with the other presenters, there may be some other people that want to ask some questions. But we do appreciate you coming here and presenting on behalf of the hospitals, and we appreciate everything you do.
Mr. Chairman, thank you.
You're very welcome. I do want to recognize one person that walked in the door. Representative Robertson and I would like to everyone in this room to know we have a new senator from District 15. I believe he may have been sworn in today or not, but please help me welcome Mr. Bart Williams, our new senator for District 15.
Thank you, Tim, for your presentation. Next, we're going to hear from the University of Mississippi Medical Center, Dr. Woodward.
You know, they gave him out.
Thank you.
Doctor, you may proceed.
Thank you, Chairman Blackwell. Thank you for having me here today. We've got a handout that is going around that you should receive in just a minute. I'm pleased to be here today to represent UMMC. Some of you in the room I know very well, and then some of you I don't know as well. So I want to touch base on a few things about the medical center that I think it is important for you to know. We are the state's only academic medical center, and that means really that we have three missions. Patient care is a very important mission, and that's one I'll speak to in a little more detail, but I want you to also be aware that we have an education mission and a research mission. We have 6 schools on the medical center campus and about 3,000 students enrolled in those 6 schools. And we have very active research programs. And just a point of pride, you know, in this year of the pandemic, everything has been different and nothing has felt very normal at all, and a lot of progress and initiatives that were underway have been stalled or efforts redirected, just like with everybody else. But I am happy to report in our world of research, actually, we secured, as this year ended June 30, $83 million worth of external funding for our research programs, which is our second highest year in history. So the research programs in a year that very much, you know, could have just been written off to the pandemic, in fact, have been very strong and vibrant and moving full steam ahead. We have the only children's hospital in the state, the only level 4 NICU, serve as the only level 1 trauma center in Mississippi, provide a lot of tertiary and quaternary care, things like bone marrow transplants, liver transplants. We play an important role in disaster response. Most of the time here in Mississippi, that means hurricane and tornado response. As you all know, since about the end of January, early February, we've played a significant role in the pandemic disaster response as well. Most of the time, it's not a pandemic, but we are active in disaster response off and on throughout the year very often. And we also have a safety net mission. A lot of states have more than one academic medical center. So a lot of states will have a center that is focused on the safety net mission and focused on those types of services, with another center entirely focused on whether it's a children's hospital or whether it is cancer care or the transplant program. In Mississippi, we have all of that in one place. So that creates a bit of a schizophrenic mission, but we manage all of it, and we manage to move all of these things forward. But the safety net mission is something that is very important to us and important to the citizens in Mississippi. During this pandemic, we have done a lot of the things that all the hospitals around the state and the country have done. We've taken care of a lot of patients. We have, as of today, in fact, discharged about 1,600 patients, some of those out of the emergency department and clinics who were not admitted. But we had today at 1 o'clock actually a celebration at the medical center because we discharged from the inpatient units our 1,000th patient. A lot of our healthcare providers who have been taking care of these COVID patients have been in the critical care units. And, there have been a number of those patients that haven't made it. We've had around 200 patient deaths. So this celebration of the 1,000th patient being discharged and making it out was actually very important for the patients, but also for our nurses and physicians and respiratory therapists who've been taking care of those patients, particularly that haven't made it. So we've taken care of a lot of patients. We have taken care of a lot of the sickest patients. We can provide ECMO and something called CRRT. Those are both almost bedside services that it's a bedside type of dialysis and a bedside cardiovascular support. So we have been able to bring some of those resources to bear that some hospitals around the state don't have those types of capabilities. And I'm proud of the work that we've done in patient care. But probably the things I think that have distinguished us the most during this pandemic response have been the things that we've been able to do that others have not. We have developed an in-house test. So by the end of March, our teams developed a test that from start to finish is an in-house lab test to test for the coronavirus. We're running some tests where it's a commercial product, and we're running some tests where it's a blend of a part of a commercial product and part of an in-house test. But in order for us not to be dependent on the supply chain, which at that time was very tenuous, we needed our own in-house test. And something that in, I think, a normal, non-pandemic situation probably would have taken the teams 6, 8, maybe even 12 months to develop if I went to them and said, we need to develop an in-house test for this virus that was not on your radar at all 6 months ago. They did in just a matter of a couple of months, really a few weeks over a couple of months. And that was our research teams in pathology and micro that really pulled everything together to make that test available. And that was a game changer for us because then we were able to run our own tests. We were able to partner with the Department of Health and run some of their tests. We were able to run tests for other entities as requested. We partnered closely with the Department of Health, with MEMA and with the National Guard in standing up testing sites all over the state, and in fact have tested multiple times in all counties. Then also we've been participant in a number of clinical trials, 25 different clinical trials that are all specific COVID-related clinical trials. So it has been very important to us to be able to be part of that and to bring that expertise to bear. We've participated, these are all national clinical trials. Some of them have been focused on test development and test validation. Some of them have been vaccine testing. Some of them have been treatment testing. So it's been a whole variety of different tests that we've been able to participate in. And then telehealth has been more important to us really than ever. We have been a very robust user of telehealth for the last 15 years, but in this particular time, when we abruptly had to shut down clinic visits and all sorts of visits that were not emergent, we pivoted quickly and scaled up our telehealth services so that we could still maintain some contact with these patients and to stay in touch with the patients. Clinics have opened back up now, but we are continuing to do more by the way of telehealth than before, and I think that that will only continue to grow. We found out quickly what we could do if we had to. We found out that some physicians who had maybe thought telehealth was a good idea, but were a little bit reluctant, thinking that it's good for everybody else, but I really still want to see my patients every time. And some of the patients who before might not have been as willing to participate in telehealth. We found that there was high satisfaction on both sides, so that has been very positive. To speak more specifically about Medicaid in this Medicaid hearing, I want to start out by saying that we see a lot of Medicaid patients. All totaled, we have about 40%, around high 38, 40, sometimes a little more than 40% of our patient volume is Medicaid. About 80% of the kids that we see are on Medicaid. So we consider the Division of Medicaid a very important partner for the medical center. We feel like that we've got the same interest at heart. We've got the same patient population that we're seeing and that we're taking care of. Partnering with Medicaid on initiatives and efforts is very important to us. They are a critical partner. At the medical center, we have a statutory requirement that we see no less than 50% of patients that qualify as underserved, and we meet that requirement. As I stated earlier, that safety net mission is an important part of our mission, an important part of what we do. I included on the handout here for you the end of September snapshot on our payer mix, and this is as it pertains to patient days. We could look at it on any given month, and it might change a little bit, and year over year it might change a little bit, but certainly in these last few years, it's been somewhat stable in this particular type of distribution. What we have seen at UMMC and in conversations with other hospitals and health systems across the state, they're seeing the same thing. In these last few months, the self-pay percentage is ticking up as we're seeing patients who have lost their insurance, lost their jobs. That self-pay portion is ticking up. So at a good level, we range somewhere in the 9 to 11% self-pay. We consider that pretty good. We're doing good when we can keep it at about that level. And you see that in September, it had ticked up to 14%. We get a report every 2 weeks, and I've seen some reports that were 16, 18%. So there's a little bit of variability on every 2-week basis and month by month. Just the most recent month report that I had was September, so I wanted to bring that to share with you, and it's at 14%. And that puts an additional strain, not just on UMMC, but an additional strain on all of the hospitals across the state as we see this percent of self-pay patients tick up. Very often what happens when people don't have insurance is they will put off something. They will delay seeking care. So I spent 20 some odd years in the emergency department at the medical center. I'm an emergency medicine physician. And what you see when that happens is a patient comes in, a diabetic patient, for example, comes in DKA, diabetic ketoacidosis, what you may have heard of as a diabetic coma, that sort of thing. And they are very, very sick. It is usually some infection that has tipped them over that edge. They can't afford their insulin, they can't afford their meds, whatever it is, that has tipped them over that edge and they get that sick. And those patients typically require intensive care unit care for a few days and then a hospitalization, treating whatever the underlying cause is, trying to get their diabetes back in control, rather than the ongoing management of a chronic disease that is much improved when patients do have insurance, when they do have Medicaid, when they've got some sort of payer source and they seek more routine care. So as we see the percent of self-pay goes up, what we also see is when they do come in, they are sicker than what you would normally expect for somebody seeking care. When you think about what we would like to see with the Division of Medicaid in the areas where we would like to see efforts and work, we would like to, and I know you've heard a lot about the MCOs in these last couple of weeks, what we would like to see if we have MCOs, if we have managed care companies here in the state and in place, what we would like to see is a requirement that the managed care companies work with Medicaid and work with the providers to manage care on an ongoing basis. Some teeth in a requirement that really requires that we see some outcomes, that we look at quality and we see some outcomes. We, just as an example, we have been in conversations for some months, I think about a year, but at least some months, with Magnolia, working on a complex children's program, so that these are children who are sick, they have multiple problems, they are very difficult and require specialists to be involved in their care. And what we'd like to do is partner with them in such a way that that care is coordinated over time to do two things. And this is what I think everybody in healthcare wants: to improve the outcomes, improve the quality, keep the children as healthy as possible, and to reduce cost. So again, we would like to see some teeth in a requirement so that the managed care companies have to work with Medicaid and have to work with the providers to really manage patients over time. During the pandemic, some of the restrictions on telehealth have been loosened and some of the requirements have been waived. We would like to see a broader use of telehealth continued past the pandemic. I think it has been a big satisfier for the caregivers and for the patients, and I think it is a way to keep in touch with patients. It's a way to manage these chronic diseases. I think on an ongoing basis, we'll be looking at ways to decrease the density of patients that are in clinics and in other places. I'd be surprised if we are not in some way dealing with spacing and crowd control and density and wearing masks and all of this, even in a year, well into the spring and summer, and it may be a year from now that we're still thinking about and worrying about crowd control. And using telehealth, whether it's remote patient monitoring or other types, I think can be a way that we can manage patients that doesn't always have to be in person in a clinic. You heard from David Elkin last week, and I just want to put an exclamation point on the things that he said. I think we need increased reimbursement for pediatric behavioral health and mental health. Many of the physicians in the state are alumni of our medical school at UMMC. When I go out and talk to the alumni and to the physicians across the state and ask them what do they need from the medical center, how can we help them, what are the things that they're having trouble with, there are a number of things that they talk about. Specialists, there are a lot of specialists. You know, neurologists, my goodness, we don't have enough neurologists in Mississippi. You know, there are a lot of things, but always at the top of the list is pediatric behavioral health and access to pediatric behavioral health. This is a type of care that requires intense clinic visits, intense patient interactions. The reimbursement rate is not high, and in most cases, these are money-losing entities. It's something that we all need, and we all need to grow. So increased reimbursement for that, it would be very important for the state. And if we can make a difference in these kids' lives when they're young, that's really what's going to get us in a different place 30, 40 years from now. All of our state health outcomes are in the wrong place on the list when you look at it. What's going to make a difference is what we do with the kids now. That's what's going to make a difference 20, 30 years from now. And then I would also like to ask that you consider Medicaid reimbursement for bariatric surgery. Again, that is a procedure that most states cover with Medicaid. We don't, but most states do. That can have a real long-term impact on the patients that have the procedure done. Their diabetes, very often they lose weight, their diabetes gets under control, their blood pressure goes down, And what we see over time is a great decrease in the cost associated with those patients that have successful bariatric surgery. So this is something that I think is another investment that we could make as a state to 5 years from now really decrease the cost associated with taking care of those patients. I'll be happy to entertain questions, Chairman Blackwell, Chairman Hood.
Thank you, Dr. Woodward. I have a couple questions for you. And this first one may be more of a Tim question, but I believe most providers would agree that from a payer standpoint and reimbursement standpoint, Medicaid generally is at the bottom of the list. So to see that almost 40% of your business is in that is kind of shocking a little bit. But I was wondering, do you happen to know how it rests with the rest of the hospitals across the state?
So I don't. That would be a question for somebody else. And like I said, our percentage fluctuates a little bit. If I got you the report for October or October of last year, it might be 35%, but it doesn't change much. It's always right around in that range, but I can't speak to the other hospitals in the state. I do know just from ad hoc conversations with a lot of the folks in the rural parts of the state that they also have a high Medicaid percentage, but what their numbers are, I can't tell you.
I see Tim standing up. Tim, you have a number? All right, thank you. And Doctor, just one more question on your bariatric surgery. How successful is that? I mean, is there recidivism in that the folks have the surgery and then gain all the weight back?
So I can't quote you any statistics, but certainly I could provide some to the committee if they would like to have that. There is some recidivism, but there are many more patients that are able to maintain their weight and actually, you know, it's one of the times that you can say somebody is cured of diabetes and actually go off treatment for diabetes altogether. So there is some recidivism, but the majority of patients are able to maintain.
Chairman Hood?
Representative Curry, you're recognized.
Sorry. One thing I want to say to you, and all hospitals have just done a yeoman's job, but the medical center during this virus has just done such a good job, and I first want to say that to you.
Thank you.
You know, none of us knew how bad this was going to be, and we weren't expecting what we got, so.
Thank you. I thought by now it would be over.
Oh, I think we all did, but I think it's here to stay for a while also. So I just want to say that, but I also want to ask you, how much of the $20 million that MCOs owe, how much do they owe you?
So I don't know the answer to that question.
I would imagine
hesitate
it's a
to
great
guess.
number with the amount of Medicaid patients that you see.
Yeah.
Could you find that out for me?
Yes, I
Okay.
can. Thank you.
Representative Scott, you're recognized.
Thank you, Doctor, for being here today. I wanted to ask you a couple of questions. One was about Dr. Elkin had come 2 weeks ago and testified to the committee about applied behavioral analysis, and they had made a recommendation similar to the one that you have here today about pediatric behavioral health, you know, increasing the reimbursement and expanding the program. We asked them, because they had asked for an increase in reimbursement for ASD, would you support an increase in reimbursement for ADHD? And since that's a part of the medical center, would you also be willing to have that in your request for consideration to come to the Medicaid committee?
I would like to speak with Dr. Elkin about that, but I would believe that the whole spectrum of care as it pertains to pediatric behavioral health would be supported. But I would need to confer with Dr. Elkins.
Okay, because, so that we can be clear, the whole spectrum of behavioral care, pediatric behavioral health care is not available right now. And so we're asking that ADHD at least be added. And the reason why we think that that's important is because of what you told us today, doctor, that when you invest in these different behavioral modification systems when children are young, and that's what you said, that's right. For us to have the best outcome. That is correct, right?
That is right. That is right.
Okay, and then now on the telehealth services, the last thing I want to ask you, do you think, because you indicated that the patients like it, and that given this situation with the pandemic, we just don't know how long we're going to be, having to social distance and make different changes in our lifestyle, particularly in how we provide our medical care. Do you think that increased managed care goals and recommendations through telehealth could possibly help our health outcomes? In essence, if we were to invest more with social workers, more with psychologists, more in the supportive services to help the whole healthcare system of people, and it be done through telehealth. Do you think if we were to invest more dollars in that would help our healthcare outcomes?
I do.
And do you think that would be cheaper, the cheapest way to do it, doctor?
I think investing in social workers, investing in educators, I think investing at all levels would be very important. More and more we are learning that health outcomes are tied heavily to the social determinants of health. So help working in a number of ways to address whatever the challenges might be that somebody is facing related to their health, whether it's a refrigerator for their insulin or whether it's money for their insulin or whatever it may be, will help us in our long-term goal to improve health outcomes.
Thank you so much.
Senator Blunt, you're recognized.
Thank you, Mr. Chairman. Thank you, Dr. Woodward, for coming today. Do you know what your annual amount of uncompensated care costs the University Medical Center?
So I looked at this today thinking that this may come up, and for last year, our uncompensated care was $168 million. Through supplemental payments, we received $152 million. So the delta of that is what we were left with that was completely uncompensated. So 16 million. Now, our portion of the assessment to draw down the federal dollars last year was 36 million. So all told, it's about 50 million. Does that make sense?
Could you say that again slowly? I need to follow you. So 168 million is total.
Right, was our uncompensated care cost. Through the supplemental payments, DISH and MHAP, we received 152.6 million.
Okay.
So that difference is 16 million that was completely uncovered. Our assessment, because the hospitals pay in to do the match, to draw down the federal funds for DISH.
Right.
Our assessment last year was, and I didn't write down that number exactly. Oh, I did, 36.6 million. So it's, yeah. It just depends on how you look at it. And I don't know how Mr. Moore, exactly which way he came up with his number, but, when we're looking at our numbers internally, that's what we look at.
Okay, great. That's what I needed. Thank you very much.
Thank you.
With unanimous consent of the committees, I'm going to recognize Representative Johnson for a question. Yes.
Thank you, Mr. Chairman. Thank you, committee. Thank you, Dr. Woodward, for being here. Just a couple of questions. I was on the Appropriations Committee back in 2014 before the Affordable Care Act was passed, and the interim then was, I can't remember the doctor's name.
Dr. Keaton.
Dr. Keaton testified before our committee that if we didn't accept the Affordable Care Act and expand Medicaid, it is interesting, the number you just mentioned, it would cost the University Medical Center upwards of $52 million a year. And he wasn't saying that as a threat or anything. It was just a realization that that's what would happen. And so I go back and look at the numbers you have on there, and I'll try to be as quick as possible. But you had the 14% for September of self-pay. You're not suggesting these people actually pay all of that. That's a burden on the hospital.
That's right. So it gets complicated pretty quickly when you start looking at self-pay, because some people can apply for some financial assistance, and so, you know, there's not a quick and easy answer to that.
Right.
But it's 14% that present with no insurance coverage.
Right.
So some of them do get on payment plans and pay some, and some don't.
Right.
We have another challenge with some of the newer insurance products that have a high deductible.
Right.
And it's very common that especially young people who are healthy and feel bulletproof and invincible, you know, get a high deductible insurance plan, and they are very happy that they have insurance, and then something happens and they need a surgery and they can't pay the deductible.
Right. So it takes me back to the question I wanted to ask Mr. Moore, but I'll get back to you. So he had a 24% increase in state funding, 2% increase in enrollment. So the 24% increase in state funding, your request from us has increased because you have more people to cover who are otherwise not covered, isn't that
That's
correct?
right, that's right.
And so without the expansion of Medicaid and without the acceptance of the Affordable Care Act, those burdens fall on the hospitals in a way of of uncompensated care and the hospital assessment that you just talked about. So my question is, then I want to ask, just all these for clarification, I want to make sure I understand. So you gave the example of the ketoacidosis condition. And you also talked about those people, the reason they get to that point is because they have avoided care because they couldn't afford care.
Many times, yes.
And so one of the proponents of the Affordable Care Act, when it was introduced, and Dr. Keaton talked about this, you know, that while back, was that the managed care portion, the important part of that was that it would manage their health. There would be a personal, a home, a health home, or something to that effect, somewhere where people would monitor your
medical
diabetes.
home.
Medical home, there you go. And so all of those things lend itself to avoiding getting to the point where you would have this very tragic and very expensive condition, because it would be managed care. Their care would be managed.
That's right.
And I'm not suggesting that would solve all our problems, but that would be the best use of managed care. I mean, would you agree with me?
So, you know, there are a whole lot of times I have to answer questions about what Dr. Keaton said.
Yeah.
And sometimes I agree and sometimes I don't.
Yeah.
But I think probably what he intended, and certainly what I have said in a number of instances, you know, people talk about Medicaid expansion, yes or no, and all the different ways to do it. What is the right thing? It's very political. People feel, you know, it's a very divisive subject. But I will say this. From my perspective, being a physician who spent many, many years working in the emergency room, and then from the standpoint of the leader of the medical center, the more people that have access to health care, the better the outcomes.
And especially you being a hospital that has a certain obligation to serve people whether they have coverage or not.
That's right.
And so I'm not asking you to endorse or suggest anything, but there are certain costs that we are incurring, increased costs as a result of not having these people covered.
These patients are not invisible in the system. They are in the system. Many times they are just receiving health care in the most expensive way possible.
Right. And so I want to go back. You talk about your cost of $50 million a year, and I want to go back to that $600 million that Mr. Moore talked about, and that increase in funding. The increase in funding for hospitals in the budget that we provide is a result of us not having the hospitals not having to serve people who would otherwise be covered. If we expanded Medicaid or had the Affordable Care Act, or if they had better jobs and had private pay, would that be a fair statement?
I think that we would have less uncompensated care costs to manage if more people had access to care and had some kind of insurance.
Thank you, Dr. Woodward. Thank you, Mr. Chairman.
Thank you, Dr. Woodward. We appreciate you coming by and appreciate everything you do at UMC for everyone.
Thank you.
Thank
Next up, we have the Rural Health Association, Ryan Kelly, who's the executive director.
I'm going to that one too. Thank you. All right, I'm gonna go to that one. Praise God.
Miss Amira, you don't have any days left, but you do have one local day left.
I don't have any days left. I thought that these folks were paying for our days.
Hey, if I could ask the audience to
Extra days, but
please be quiet.
management denied it. So if you want to use one of these for today, you can. Yes, ma'am.
Okay, so they say I have already used 3 days?
We're going to get back to the hearing, please.
Alicia was telling me, and she said.
Those in the audience, if you would, go outside if you need to converse.
Okay, and so.
Mr. Ryan, or Kelly, go ahead.
Good afternoon, Mr. Chairman, Mr. Vice Chairman, distinguished representatives and senators here in the state of Mississippi. We thank you for this hearing. Thank you for your leadership in the state, especially anytime, but especially the year 2020 with all the difficulties that we faced. I appreciate the invitation to come before you today. I'm very humbled and honored to be here, especially before presentations from Dr. Woodward and Tim Moore from the Hospital Association. My name is Ryan Kelly. I represent many different groups in the state. If you know me, you know I probably have, actually I represent 21 different organizations. I'm coming for you today before the Mississippi Rural Health and Mississippi Telehealth Associations, primarily because these two organizations are so clearly aligned on some very important issues respective to Medicaid. Although some of the other organizations that I represent have elements that touch on it, these are the two that I believe align most important. I'd also like to just mention that I largely agree with everything that Dr. Woodward and Tim mentioned earlier, and knowing that they came before me, I figured that I would redo my entire presentation and not touch on necessarily numbers or figures, but something that dives a little more deep into just the rural. Some of it is a little more anecdotal, and if you know me, I'm a fan of brevity, so the presentation or the packet that you have before you is about as short and sweet as I can make it. And that is simply because I don't necessarily believe you want rhetoric. I think you want some things that will actually get the point across. Rural health in Mississippi. Many of you live in rural. You're very familiar with rural. We have currently 32 critical access hospitals, 44 rural hospitals, 186 rural health clinics, and 197 federally qualified health centers that are all representative of some element of rural in Mississippi. The Rural Health Association consists of about 1,800 members statewide. The Telehealth Association comprises members that are focused in or indirectly around telehealth throughout the state, including membership from the University of Mississippi Medical Center and a number of other hospitals, clinics, and entities, including some corporations and for-profit businesses that are using telehealth for their patients and their employees for self-insured and fully insured healthcare plans. So regarding telehealth, we believe that it's not a silver bullet for anything, but it is absolutely the best way that we can solve many of our healthcare issues, primarily dealing with preventative health and primary care. And then so many other areas that I'd like to dive into as well. The reason I like to do so many things in this state, the reason you probably will see me in a lot of different areas is because I firmly believe that our state is only as strong as our least healthy people. We are never going to be the state that I believe that God has designed us to be unless our citizens are healthy and successful. And I don't believe you can talk about healthcare unless you start talking about economics and education as well. I'm not going to talk about the latter two, but I do fundamentally believe that that three-legged stool is critical for helping all people to gain access to healthcare, a successful life. And ultimately, as we're talking about Medicaid, my ideal for Medicaid would be that we don't have a single patient on it, because you're only on Medicaid if you are lower income, and I don't want anyone to be of low income in this state. So ideally, we want to try to get people successful so they're not having to be on this program, but we also want this program to be the very best that it can be while our patients are on it, while they're seeking that better life with higher income and more success, and then moving to a commercial plan or whatever they end up moving to after that. I'm going to focus on a few things, obviously the good, and then some of the things that we can do as constructive opportunities to move Medicaid forward. And there are so many good things about Medicaid right now. I've certainly bragged both in-state and especially out-of-state to constituents of mine across the country at how good our state Medicaid program is. As Senator Wiggins, you pointed out, Tim mentioned earlier, the staff of the Division of Medicaid are phenomenal. Drew Snyder is a fantastic director. He's got great staff, leadership from the top down. I work with them very frequently on the number of calls and issues that come up, and they are always very diligent in jumping on them and trying to handle them as quickly as possible. And we really appreciate that, because I've dealt with programs that do not do that and try to just pass the buck off or hide things under a rug, and I do not believe our Division of Medicaid does that. I do believe that there are a number of issues that are very difficult to manage when you have, probably a very lean budget and a huge number of patients in the state to deal with, and a number of claims that are having to be dealt with. So they do a great job, though I'd like to definitely commend them again for that. They've focused in the last several years especially on a very aggressive approach of quality, and especially focusing on telehealth. And I think we've done such a great job, especially since 2013, with, I know many in this room passed telehealth guidelines allowing telehealth to be reimbursed in the same level as in-person encounters. That set us on the track to be one of the best in the entire country for telehealth, and I think we're still there right now. Some of the things that we've done just this year during the emergency orders have continued to push us towards being the very best in the country for telehealth, and you better believe I brag on that to all of my colleagues in California and New York who like to pretend that they're the best at things, and I like to remind them that that's not necessarily the case. We are innovative, we're solution-oriented, and I believe that's the direction we're trying to go with Medicaid. And here in 2021, I believe there's a lot of opportunities for us to continue to push in that direction. As I mentioned, they've handled significant issues that they've come up, and they've been very good on communication, sending individuals to trainings and events for our providers to teach them better ways to handle claims or ways to overcome some of the obstacles that have been in front of them. We have a good partnership with the Mississippi Managed Care programs, the CAN programs. They also have been eager to try to solve some of the issues that they've come up, usually on a case-by-case basis, and we appreciate their attention to some of these issues as they have come up as well. During the emergency telehealth orders in particular, some major things happened that we knew needed to happen. One, rural health clinics and FQHCs were able to bill as distant site providers. For those of y'all who are not familiar with the terminology, I'm probably going to throw some terms out that you may have never known or forgotten about, or maybe never cared about, and that's okay too. Distant site means you're the person who's delivering telehealth. Originating site means you're the patient receiving telehealth. The originating site at this moment can be the home, it could be a school. These are both things that were opened up during the emergency orders this year. You could also be in another clinic, you could be in a hospital. Wherever that patient is, that is the originating site, and wherever the provider is, whether a physician or nurse practitioner or licensed clinical social worker or whoever else, that is known as the distant site. So rural health clinics and FQHCs, as of the emergency orders, can be those distant sites, allowing them to therefore furnish telehealth. So if you're a rural clinic in, let's just say Aberdeen, Mississippi, you now can provide telehealth to your patients, to your Medicaid patients, regardless of where they are, including in their home. During the world of COVID, this is tremendously helpful, not to mention just all the time. Much more convenient for patients, much more convenient for providers, and they've loved it. I don't have the numbers on Medicaid in Mississippi, but I can tell you that Medicare, CMS, and this seems like I've just made this number up, I know, 17,000% increase in telehealth utilization during the start of the pandemic. That's a ridiculously high increase, and it was already increasing prior to the pandemic. One would assume that once the pandemic started calming down and we started having people back in clinics and hospitals, that number would have decreased substantially, and it has not decreased substantially. It is down to only 12,000% increase since the beginning of the pandemic. Still an extremely laughably high number. To me, that just means Pandora's box is opened. Patients like it, providers like it, and we know that for the things that telehealth can do, it is substantial, it is as good, or sometimes even better in some cases, than in-person encounters. And by better, I'm primarily meaning behavioral and mental health services, which are actually getting better scores and better quality than inpatient. And I've got reasons for that, but I'll answer that question later if anyone's curious. And then I also would like to thank members of the House and the Senate and distinguished guests here who were part of, directly or indirectly, the Governor's Rural Health Task Force plan that I was able to chair last year for Governor Bryant, still used under Governor Reeves this year. I know Tim and Drew were both a part of that, and then a number of individuals in here that had at least indirect involvement in it. This is our rural health plan for the state. This is what we're using. The recommendations that I have before you here are both a mix of what we looked at during that plan, as well as feedback from all of our members, both from our legislative committees of these two organizations and from the many, many phone calls that I get on a weekly basis with people giving me ideas and thoughts and concerns that they have and how they can be addressed. So I write them all down, and this is the culmination of a lot of hard work and feedback from many, many different individuals, and so I hope it is helpful. So getting just the high level, and then I want to dive in, and I'll be quite honest, I know that many of the recommendations in here are probably not things that are going to make the front page of a newspaper. They're minutia. But minutia is why we're in such bad shape right now, because the minutia drags the system down. Red tape and inefficiencies create all of these bottlenecks that we have. And I believe that everyone from the team with the Division of Medicaid, the Medicaid CAN programs, and our providers and patients all want these things to be streamlined. And so I believe that getting in the weeds is sometimes the best place to be. Creating more efficiency, I think, is critical. I believe we all would agree that efficiency is the key for us to be successful. I believe that many of the things that Medicare is doing right now, we can follow the lead on by creating some smart programs, smart reimbursement changes, and allowing our providers to just basically align. When you have Medicare and Medicaid that are both aligned with their focus, it makes it a lot easier to keep track of all the changes and the updates that happen. Ensuring that our CAN programs have the tools and can create value in the way that they need to, and they follow the Medicaid guidelines. I think that's one of our critical things, is to ensure that our CAN programs, as our providers see what these policies are for Medicaid, they don't have to wonder, is Molina, United Healthcare, and Magnolia going to have something that's different, or something they have to jump through that's a different process, a different rule, a different guideline. We got to have them all the same. These providers have to deal with enough with Blue Cross and United Commercial and these other plans. They're in the business to just take care of patients. They went to medical school or nursing school to treat patients. They're not businessmen and women largely. They just want to take care of patients, and all this other mess that we're bogging them down is one of the reasons why healthcare costs drive so high, is because we're all fighting over the same dollar over and over. So you hire more people, and you're fighting over the same dollar with audits and down-coded claims, denials, when if we could just trust providers to do the right thing, punish them if they do wrong, but assume that they're going to do right, and let's just let them go. They're going to take care of their patients, and largely they're going to do it in the most efficient and cheapest way possible, especially if we incentivize preventive health, which is a huge part of what I think we need to be doing. And then a strong focus on telehealth. Representative Scott mentioned earlier preventative health. I think that's so critically important, and probably half of what I have here in front of you is focused on telehealth in the way of prevention and wellness. Because if we can spend more money on the front side preventing heart attacks and strokes and diabetes, then we are going to save thousands of a percent on the backside by not having strokes and heart attacks and people on insulin for the rest of their lives. Let's take care of them on the front side, spend pennies on the dollar to do so. They're going to be healthier, they're going to be happier, not to mention the whole economic side where these patients are going to actually thrive and work. They're not going to have to worry about the fact they can't breathe because they're having congestive heart failure or diabetes that's affecting their limbs and they can't walk, and they're just trying to make it through whatever job they have. If we can take care of them health-wise on the front end, which is cheap and easy, they are going to be able to do better economically, grow their way out of the fact that they even need Medicaid, and then we have one more family breaking out of that cycle of poverty, breaking out of that cycle of resistance in this world. So let me move on to the recommendations if I can. And again, these are not glamorous, but they're very important. And so if you call your attention to, I guess it's what's page 3 of your booklet, that goes through a few items. Each of the ones with a title in blue is a separate item. So I'm going to go through them relatively briefly and just focus on the highlights, and then, of course, entertain any questions that you have at the end. The first is probably the easiest, updating the definition of telehealth. This is within the Medicaid statute and Medicaid code. It's just simply an outdated terminology. Using the term, the use of technology to deliver health care is the simplest way we can call telehealth. That grows every opportunity for Medicaid and our governing boards that are using this definition to then govern Medicaid, such as the Board of Health. They're having to use an outdated definition with what the board is about to vote on soon to govern Medicaid, because we just need to update this definition. So it's from section 4.2.3 dealing with telehealth, just simply rewriting the definition to cover all technology using healthcare, because that ultimately is what telehealth is. In case anyone's curious, the difference in telehealth and telemedicine: telemedicine is using technology to deliver medicine for the sake of patients' direct care. Telehealth can be anything like remote patient monitoring, chronic care management, store and forward services like radiology, and similar other types of even wearables like an Apple Watch. All of that can fall under the realm of telehealth. So for the future, when you're writing legislation, if we can just simply have a broad-based definition, then the sky's the limit for what you can do. Right now, with using terms like e-health and m-health and all these other things, they're just outdated. And that will set the stage for the rest of what's in this booklet here. This is in no particular order, by the way, so it's not necessarily an order of importance. Permanently extend distant site allowances for RHCs and FQHCs, or as I call it here, community health centers. I use those terms simultaneous. That is simply, it's been extended through the emergency orders. This would just simply allow it to be permanent. A number of these things we've discussed with Drew and the team at Medicaid. They agree that, well, Drew, I don't want to speak for you, but I believe most of all of these, the team at Medicaid agree are good policies and things that we're trying to work towards. So these are things we've done during the emergency orders, but this is something that we humbly ask that are extended permanently. This is no extra cost to the state. These are the same patients coming in person. We're just simply creating efficiencies for providers. They don't have to use it, but it's good for them, and they're using it right now, and they're doing very, very well for their patients. They like using telehealth. It's more efficient for them. They can actually see more patients, therefore creating more access to care, and all of them are focused on the wellness and prevention side, keeping these patients out of the emergency room. And that's essentially most of what we're trying to do here. Let's get the patients into the lower cost of care, get them healthy, and keep them out of our ERs. Because although we love our ERs and we need sustainable ERs, we don't want patients going to the highest cost of care for something that they could be treated on through primary care, either in a clinic or via telehealth. Removal of the prior authorization for remote patient monitoring. Right now, patients through the Division of Medicaid have to have at least 2 hospitalizations or emergency visits as a condition to be on remote patient monitoring services. Remote patient monitoring, if you're not familiar, is essentially you are at home and you check in every day or so with a provider who's monitoring your vital signs, blood pressure, heart rate. You enter what you ate that day, and like UMMC is a good example. They have a team of people in their Center for Telehealth. They're not the only ones doing this, but it's a good example where they're monitoring all the data coming in, and it's flagged anytime something comes through. If someone has sustained high blood pressure, maybe they ate too much salt that day, they're getting off their diet, maybe they're not taking their medication. They check in, and so we can jump on just like this every time there's a problem, way before they're in need of a clinic visit, way before they even notice a health issue. We can jump on there and then go and check on them and make sure they're compliant with medication, they're compliant with the prescription orders from their provider, and we keep them healthy and out of our healthcare facilities. Again, pennies on the dollar for remote patient monitoring services. But if we already have 2 hospitalizations, we've already that's all of our cost right there. So we have to wait for the patients to get really, really sick before we take care of them from wellness and prevention. If we could just do that on the front end and allow providers to enroll chronically ill patients or beginning to be chronically ill patients, pre-diabetic, pre-hypertension, then we can save ourselves millions and millions of taxpayer dollars per year just by keeping these patients healthy, not to mention the fact that the patients are healthy. Elimination of the site of service requirements. We have extended, and thankfully to the Division of Medicaid through the governor's emergency orders here, extended sites of service to the school, and we're having a number of school-based telehealth programs popping up across the state just in a matter of the last few months due to these emergency orders. We also have the home as an eligible site of service right now, which is tremendous, especially during COVID, but at any time, allowing the home to be a site of service is good, especially for our elderly patients, for mothers who have recently given birth, for those checkups that you have to drag the baby. And I know if y'all, all of our mothers and fathers in here have packed up a diaper bag, gotten the baby in the car, gone all the way to the clinic, sat there for an hour just for them to look in, check a few things, and say, okay, you're good, go ahead. And we could do that via telehealth. Again, when it's safe and effective for the provider and the patient. And I think we can trust our providers who have gone to medical school for 4 to 8 years to make those justifications. Allow more providers to provide telehealth services. This includes, and I listed a few examples on here, but certainly we can entertain others, physical therapy, occupational therapy, and speech therapy services, all of which can and are currently reimbursed through CMS, through Medicare, along with dentistry and pharmacy, which we also believe there's some excellent models at extending these to just allow dentists and pharmacists, along with your PT, OT, and STs, to have additional options for providing care. And if nothing else, it keeps the pharmacy open longer. It allows your therapist to provide therapy to patients that maybe cannot make the trip in or have other conditions that lend themselves to not be able to make it into an in-person encounter. Eliminate requirements for telepresenters. Telepresenters are extremely effective in some cases, and in some cases, they are a best practice. However, again, I come back to the fact that the providers are the best ones to determine whether a patient needs a telepresenter. A telepresenter is basically a staff person that is there with the patient to help them, take blood pressure, monitor heart rate, take their temperature, get the peripherals up to the patient and monitor different things. There's times where you absolutely have to have a telepresenter, but to write it into code is very difficult to do. I believe we should allow our providers to say, no, I'm sorry, Ms. Jones, we cannot do telehealth with you because we're going to need someone there with you. Let's say that patient's in their home or at school or at work. But then in other cases, they can, and many cases, they can provide telehealth without the need of a telepresenter. So we would just simply like that to be changed from a mandate to a recommendation. Recommended telepresenter, but not a required telepresenter. Again, small changes that make tremendous differences. Create and enforce a single source credentialing for all Mississippi CAN providers. I know that Tim mentioned this, and Dr. Woodward may have as well. This is something I know we've talked to the Division of Medicaid about for several years, and several of our legislators in this room for several years. We have got to streamline the process of credentialing and provider enrollment. If there's one single problem we have right now with the Medicaid and the CAN programs, it is that we have 4 different processes for enrolling providers. So if for Medicare, it takes reportedly from our members 2 to 3 weeks to enroll. You hire a provider, you apply for Medicare, 2 to 3 weeks, you get it back, you're good to go. With Medicaid, it's still pretty quick, 3 to 5 weeks with the Division of Medicaid to enroll a provider. That's not a problem at all. But that's step 1 of then enrolling with the Medicaid managed care programs, because then you have to go through their credentialing and provider enrollment processes, which I don't blame any of our people here in the state because they are simply following national guidelines of what are required of them. And I like to point that out. We have some excellent people with United, Magnolia, and Molina in this state who have the best interests of patients and providers at heart, and they want to be as efficient as possible. Some of these things, quite honestly, I believe are outside their hands. If we could just simply mandate that participation in the CAN program means you follow Medicaid's program for credentialing and provider enrollment. Credentialing, all that is just verifying someone went to medical school, they don't have pending lawsuits, that what they put on their application is what it says that it is. That's a pretty simple process. That should not involve weeks and weeks and weeks or months and months of waiting. And then the provider enrollment process still is a relatively simple process. Medicare can do it, and they're a national program. I'm not sure why we can't do that as a state. It takes between, reportedly to me, up to 4 months or more for our providers to enroll in our Medicaid managed care programs after they've already had to go through the process with Medicaid. And what this results in is one of the most critically important issues I can bring to you today. It's called the effective date, when that provider is eligible to be billing to Medicaid. And that effective date sometimes is the date of the first application. Sometimes it's the date of when they were asked for a change to that application. Sometimes they're substantial, sometimes they're not. And then sometimes it's just a random date that's assigned. And I really can't tell you, I'm sure our representatives could tell you what the reason for that is. And there's a number of pending lawsuits and complaints right now that I can't share publicly because I don't know what status they are legally from their legal teams. But this is a huge, huge problem for millions and millions of dollars of claims left on the table that hospitals and clinics, they work as hard as they can, as Dr. Woodward said and Tim said, spend all this money to hire a physician. Great, I've got a physician. Now I'm going to go through the process of enrolling them. 4 or 5 months later, you finally get enrolled to a program that doesn't even pay that much money. Let's just be honest. And then they're not even going to get all the claims back of all the patients that they treated during that time. I mean, that in itself is just a horrible thing. And I know our CAN programs agree. I don't blame them. I just believe there's a fault in the system, and we've got to be more efficient and effective in how we do this. I defer to the Division of Medicaid and to our elected officials in exactly how you want to do it. But my recommendation is just make it simple. One application, one enrollment process. They can deny the enrollment if they want, but just make it easy on the providers. And let's cut down some paperwork, and let's make this as efficient and effective as we can be. I don't believe that's going to harm the CAN programs at all. I think it's honestly going to save them a lot of money because they won't have to go through all this process. They're having to hire people to do this, and they could transition those people into more case management and quality-based outcomes versus just having to shuffle paperwork. And I would also like to point out on this, the top part right above that second point here is important to note that this should be done by inserting a requirement in the contractor's enrollment process that mirrors current requirements from the Division of Medicaid Administrative Code, and that's Rule 4.4, 211, and Part 200, Rule 4.4, 211, Rule 1.1, and 212, Rule 1.1, already in the technical code. We just need to enforce it for our canon contracts. The next item on here, reimbursing for inpatient services. This is respective to telehealth. There are a number of inpatient services that Medicare reimburses for, and I've listed a number of different codes on here that I'm sure no one knows, and quite honestly, I'm not a coder, so I can't tell you every single one of these. I can look them up for you, because I do have my notes on my computer here on exactly which ones these are. But these are a number of codes that Medicare reimburses for that we believe would also be effective for Medicaid. And these codes will allow telehealth to be delivered to patients to inpatient. Now, you may ask, why are we doing telehealth when the patient's already there in the hospital? It's a good question. There's several reasons that this could be effective. One is a hospitalist. Telehospitalist programs are critically needed, especially in our rural and community hospitals. This is when a physician comes by and checks on a patient. You can do that effectively through telehealth, especially when a hospital doesn't have a physician that can round. That's one of the hardest things about recruiting a physician is having them do rounds in the hospital at 2 o'clock in the morning. If you can move to a telehospitalist program, which other states are doing, we can save money, we can make it easier for the hospital to run, and all we have to do is just reimburse for it. Inpatient dental services, I'll be honest, I was actually in a clinic just 2 weeks ago when I had a patient crying and walking out the door, and I asked why, and then a provider there came up and mentioned to me that they had a child who needed dental services, and they were, I think, 12 or 13 years old, and they had just anxiety over it, as I'm sure some adults in here would too. I think it was a cavity fill or something like that. And they needed nitrous oxide to just calm them down a bit. But apparently, and this is just news to me, that Medicaid currently limits reimbursement for dental services in the inpatient setting, and it's really very unclear, depending on who you ask. Anyone over the age of 7 and under the age of 18 is ineligible for nitrous oxide. And I don't really have an explanation for that, but I felt that was so important as to add it to this report in the last minute. And perhaps there can be some clarity on that. But this is, I think, an example of where we can streamline and just create better efficiencies. Again, minutia, but important to those families whose kids, that kid is not going to get dental services right now because they were freaking out in that hospital trying to get out of there. And we need to be able to provide that level of care for those patients. And because that could become an abscess, they're going to end up back in the ER with extreme pain. And now that went from a $100 visit to possibly a $5,000 visit just because we didn't provide nitrous oxide and allow the kid to have a cavity filled. Possibly, maybe not, but I'm sure this is an example of many things that are happening. Adoption of these CMS codes on here. I'm not going to read them off, but there's a number of them. This would entitle patients to monitoring to the monitoring entity for remote patient monitoring services. These are when remote patient monitoring is held, you've got generally nurse practitioners there sitting and looking at these monitors. But then there are times where they have to call the primary care provider or a specialist at times to check on it and find out what the deal is, and then call the patient and then inform the patient. That provider cost is actually not reimbursed right now. And so this is just basically gratis from the provider to contact that nurse and to then contact the patient. So it's just simply adoption of a few billing codes here to allow those providers to receive reimbursement for their time and effort for chronic care management and remote patient monitoring services. Excuse me, remote patient monitoring, not chronic care management in this case. Transitional care reimbursement, same, very similar thing. These are services that are mandated. Transitioning from one setting to another is a requirement. Takes a lot of time, costs a lot of money, but it's not reimbursed right now. CMS does reimburse for transitional care, but Medicaid does not. We just simply recommend these billing codes be added so that transitional care can be reimbursed. And again, this cuts down on some of the uncompensated care and some of the costs that our facilities are incurring right now. They're just hidden costs that end up eating into their bottom line. Reduction of Medicaid audits and rejection of claims. This one might be the second most important that I could come to you today. There are a huge number of audits, both from Medicaid itself and the managed care companies, that providers are facing. And I've actually sat through a couple of them just to see how they go when it comes down to the hearings. And there's no reason why many of them should be audited. They are being audited and their codes are being downcoded, and they're having to fight this battle for reasons that honestly I can't understand as I look at them. I don't want fraud and abuse in our system in any way, shape, or form, and I think that our state auditor has done a fantastic job at going after waste, fraud, and abuse. I've not seen many examples of it with the audits that I've personally looked at and the providers I've seen. I believe they had the best intentions in mind. They were not trying to defraud the state or drive up costs or have improper care. They're just simply trying to do their jobs, and here they get an audit letter in, and it takes hours and hours and hours of their time. And honestly, most of the times that the codes are rejected, the claims are rejected, they don't even fight it because it's not worth their time. So facilities are losing millions of dollars on the table just because you don't have time to fight a $500 or $1,000 claim that's rejected. You'll take the time to fight the $10,000 or the $20,000, but none of these, honestly, should be rejected in the first place. If we could simply trust providers to do their job and just go after those that are egregiously abusing the system, I believe that we'll have a vast reduction of cost overall. And then a simple one on the end, ensure that the Medicaid managed care plans are following state statute. There's a number of issues that have been reported to me and I'm sure to many where there's guidelines that are not necessarily being followed. As it mentions on here, 21 chronic conditions that are termed acute conditions for COVID-19. They are Medicaid statute mandates that reimbursement for remote patient monitoring refer to chronic conditions as defined by CMS, but currently it does not appear that we're listing COVID-19 as one of those RPM-related chronic conditions. So this is an example of other ways that I believe we can follow Medicare's lead when it's involved in state statute and just continue to evolve our healthcare reimbursability based on the guidelines we already have. Again, I apologize because I know that a lot of this is minutia, and it's probably things that many of you are not necessarily interested in, but I believe that these are good examples of ways we can make very smart, targeted changes that will continue to improve our Medicaid program, and again, hopefully improve the quality of care and improve the quality of our patients' outcomes, and ultimately get them healthy, happy, and as productive citizens in our society.
Thank you, Ryan. Does any committee members have any questions? Representative Zuber, you recognized.
Thank you, Mr. Chairman. Mr. Kelly, thank you for your very insightful testimony this afternoon. You caught my attention whenever you gave us the percentages concerning the increase in telemedicine in Mississippi.
Yes, sir.
Sir, my question to you is, with that increase, are we experiencing the same level of decrease in transportation costs? And if not, why not?
That is an excellent question. Thank you for that. Honestly, I've not seen the numbers of transportation costs. I would certainly assume that to be the case, that both non-emergent and emergency transportation costs should be lower, or maybe I should say the utilization of those services should be lower. Now, I know that with ambulances alone, I've seen numbers around $1 million per year to operate an ambulance along with the support services, and those are fixed costs. So they're going to exist, kind of like an ER, they're going to exist regardless of whether you use them or not. That gets into probably an entirely other question of how you reimburse for such services that you need them, but you never want them. You never want to have to use them. So it's a good question. I'm not aware of a decrease in the cost. I feel very sure there's been a decrease in the utilization, both with respect to use of telehealth and also just the simple fact that people are staying at home. They're not necessarily doing the things related to car accidents and gunshots and the other things that are involved for emergency care.
Mr. Chairman, if I may, that may be a better question for Drew, if he was willing to take that question. It has gone down? Okay.
Any other questions from the committee? Thank you, Mr. Kelly. Appreciate your presentation.
Thank you very much.
Next, we have Ambulatory Surgery Centers, Tammy Burnett, who's the Executive Director.
But that didn't even make sense to me. Now, it might have made sense to you, but it didn't make any sense to me. At OT. Now, I can see pharmacy.
Welcome, Ms. Burnett. You may begin at your...
Good afternoon. Thank you. Here with me today is Leah Etheridge. She is our chairperson for our Provider Communications, Provider Relations Committee. I want to start off telling you a little bit about ambulatory surgery centers, and thank you guys for allowing us to come and speak today. Got this a little last minute, and I'm not used to not speaking, obviously, to you guys a lot. I'm usually in a small room with physicians and administrators, and I'm a nurse, so I'm used to taking care of patients and not necessarily talking to a room full like this. Mississippi has 72 ambulatory surgery centers. You'd be hard pressed to find anybody in the room who either hasn't been in one or hasn't had a family member one in here in the state. When I started doing this quite a while ago now, I can actually go back to when we started our last facility here in the state. It was probably 2005. I think we had over 100. I think the number was closer to 118 ambulatory surgery centers. But again, today we have 72. 21 of those are what's considered multi-specialty, CON required certificate of need facilities, meaning very different specialties work within that facility. So that leaves 51 of the single specialty CON exempt facilities, and those are, as some of you know, are considered extensions of a physician's office. These range from small 2-room surgery centers, such as eye centers, pain centers, up to even some of the behemoths that many of you know as GI Associates and Mississippi Sports Medicine. Those are single specialty facilities. ASCs and ASC owners typically pay in taxes about the same amount annually as they pay out in distributions to their owners. Our median income for a surgery center employee is about $58,000. A full package with compensation and education adds about another 35% on that. Out of that rate, our employees are majority homeowners and parents who participate fully in the community. We also, as ASCs, participate in our communities, giving back to charities by providing services, monies, and our staff volunteer both paid and unpaid. ASCs across the country have stepped up to provide safe patient surgical procedures during the COVID crisis. While Mississippi's ASCs did not specifically end up doing this, there were preparations made for this to safely occur. And again, it has happened across the country. Our ASCs have continued to provide quality procedures during the pandemic with little to no effect on hospitalization and PPP usage. ASCs provide value to the state. We're a lower cost alternative for surgical cases, in some case by as much as 200% on some procedures. In certain states, there are procedures that are mandated to be done in ASC alone, unless medically warranted to be done in a hospital. That's not to say that we position ourselves in any way as to not say that hospitals don't do a good job, because they do, and there by the grace of God goes me, I don't need one. We're just saying that by, like anything else, if you build a better mousetrap and you're more efficient, this is just an outcome. Surgery centers are an outcome of that. It's what you do it well, so you find a avenue in which to do that. And we've got a handout, whether we didn't print the thing because it's very thick for everybody, but there's also a link on our website to a study that we will provide for you guys that says reducing Medicare costs by migrating volume from hospital outpatient departments to ambulatory surgery centers. This was done by K&G Health Consultant and distributed by our National Ambulatory Surgery Center Association. Mississippi Ambulatory Surgical Center Association has a great relationship with Medicaid and managed care organizations. We have a great relationship with Drew and Aaron and Mitch, and sadly I don't know as much about the Molina group and Bridget because we just not had need to call them yet. So they do a really good job. I think they seem to have, from all accounts that we know of, saved the state some money. They're very invested in having a lower cost, providing a quality outcome. So in that way, they partner with us. We do have some issues that I think several people have already spoken to, so I won't go into great detail about a lot of those, but just to say that they are of the same issues, such as credentialing. It is problematic. As last speaker said, there are 4 different ways of doing it. It's going to take ever how long it takes, and it's hard to tell people. I will say he seems to get Medicare done a lot faster than we do, because sometimes it'll take as much as 6 months. You send them something and it's a 45-day wait before they even answer you. We do think there needs to be a more cohesive process there. Most of the commercial insurances use CAQH, which is the Center for Quality Health. That's all they do is credentialing, and most of the data is kept there like a national database, and the insurance companies just check that and get back with us and keep their information up to date. It's not, we frequently will have within credentialing, even within the 3 entities that I manage, from day to day, I'll get a note that, oh, well, they say we're not in network today. Or somebody was termed over a piece of paper that didn't get through, or it was lost or misplaced or something. Anyway, that process could be a lot better. Along that same line is just issues with prior authorization. You're trying to get prior authorization for surgery. Again, it's 4 different ways of doing it. I know in my facility, I'm thinking Leah's as well, we hire somebody that's all they do is specifically prior authorization. And you better know what you're doing, because if you don't, it's definitely mother may I, and get everything all I's and T's dotted up front, because you're going to provide a surgery, and at the end of it, you may not get paid. Utilization review is another, I think, that kind of goes under this same category that could be streamlined. Each has its own process. I'm not saying it's necessarily bad but it could be streamlined in the same. I'm gonna go up and put Medicaid transportation here, and I'm gonna let Leah talk on that. Medicaid transportation, and the reason it's on here, this affects surgery centers in the way as, and I'm sure y'all could have a whole meeting just on that. And we couldn't presume to tell you what to do with it. I was just telling you it's a problem. We frequently have Medicaid patients scheduled for surgery that don't show up, either didn't get their transportation worked out, or they show up and they don't have a family member with them that's going to be with them that we can instruct on taking care of them in the next 24 hours. The Medicaid driver's obviously not going to sign for them, so sometimes we have to cancel those cases. Or at the end of the day, transportation doesn't come back and pick them up. What do you do with that patient? They're ready to go home. Can't take them home with me. They've got to go somewhere. So those are issues. Those are ongoing issues that we ask you guys to take a look at. With that, I'm going to let Leah speak to these other two.
Hi, thanks for listening to us today. Two other issues. I'm going to jump to communication. It's usually not a huge problem depending on what you're dealing with, but sometimes on the admin level with the higher level payment issues, it's really hard to get through to really advocate and explain what we're trying to do, because when you're somebody like me who really knows the payment side of things, I will bring you a case when I'm going to save you money. And we're up against the hospitals, and we try to work with them, but I had luck communicating with with Melina and Magnolia on, for example, a pediatric dental issue where they were seeing EOBs and paying back. This is Melina and Medicaid, or Melina and Magnolia, paying EOBs as high as $15,000 for pediatric dental cases because they were done in a hospital. And we're here in a surgery center. We used to get about $500 minus our 5%. And then all of a sudden, we started getting denials and getting paid half of that, which was about $249. $249 for a facility to take care of a patient, to extract several teeth. These are Down syndrome, these are ADHD. These are not kids that might have one little cavity. These are patients that the dentists know it is unsafe to try to anesthetize in their office, so they need to put them under and take care of their teeth. So $15,250, and we can't afford to do it anymore. So trying to get through to Medicaid to say, hey, please just listen to us, just give us enough, we're not trying to make a bunch of money, those kind of issues we need to open the doors with, whether legislatively or administratively or both. And I could talk to you all day about that specifically, but also there's lots of times where the doctors will call me and they'll say, hey, I got a broken wrist I saw in the ER last night, it's Medicaid, and I need to I need a full tray. I need to put a lot of metal in their wrist, it's really bad. It's a fixation tray by this company, it's the cheapest I can find. We do our groundwork, we find out it's $2,200. Well, our full allowable at the surgery center is $875. So we have to say no. Well, then they go to the hospital, and granted, if they do an ORIF, for example, which is a wrist fracture, a patient will get billed one CPT code, nothing extra, nothing for the meds, nothing for the implants, no extra. You don't get an itemized bill. You get one CPT code, maybe two, depending on the case, and you get X. So when we at the surgery center are delivering this care, we already know how to be efficient. We know how to manage our money very, very well. But when you're dealing with a cost of a case that's $2,200, $5,000, even $1,800, and you're getting $250, $1,200, or $800, you can do the math. We can't survive with that. And trust me, we've done cases where we've lost money because we've added them on, and we take care of our patients. But in these drastic situations, we have got to do a better job of working together, legislatively, administratively, and at our operational level, because I can tell you we could save our state so much more money, because we are paid 80% of the already reduced fee schedule from Medicare. So Medicare has a national rate of 1. In Mississippi, depending on where you are, but mostly rural, you're going to get paid in an ASC about 72 to 75% of the national rate. Then ASCs get 80% of that. Then there's the 5% extra that you all have heard about through the years that we take off of that. So doing the math, we don't get much for what we do, and we try really hard. We take care of a lot of kids. We take care of a lot of patients every day. But there are a lot more opportunities to take care of a lot more Medicaid patients in our facility at a lower cost, at a very low infection control rate, at a high quality, and we do it well, and we do it every day. So those are the two issues, communication, payment, and we did talk about transportation. So in summary, do you want to summarize?
Well, some of the goals that we put on there, we've talked a little bit about those. A centralized way to do your prior authorization, credentialing, utilization review. A little bit of better communication with detailed processes where things are duplicated and there's 4 different ways of doing things. We'll work to assist you guys anyway with this transportation issue. Is anything reasonable? We're on board to help. Just tell us what it is. You know, we'd like to see, Leah was talking to me a minute ago about surgery centers being paid 80%. I want to explain that a little bit. Providers in the state of Mississippi are paid a percentage of the Medicare program. To my knowledge, the ASC group is the lowest paid at 80%. Some of the providers are not discounted at all, like physician providers are paid at 100%. My understanding, I believe, hospitals are paid at 100%. We are paid at 80%. And again, like I said, that's the rates for Medicare are a little different by geography nationally, but then that rate is reduced again by 20% before it's just not a straight pass-through. And then there's also, like I said, the state assessment of 5%, which we've asked to be out of, to be released from on different occasions in the past, because that's not attributed to every medical provider in the state. So we would look at that. And we'd also look at like you guys to look at the possibility of what some of what managed care wants to do, and in moving some of these cases, mandating that some of these cases be done in an ambulatory surgery center, strictly because of the payment differential. I pay taxes. I'd like to see my costs go down. I know ambulatory surgery centers, the surgeries are not a big ticket issue, not one of the biggest ticket issues for you guys, and that's obviously pharmaceuticals and skilled care, but we could save you a lot of money. I've worked with the numbers with several of the managed care groups, and I know what those numbers and know what they're paying, and it could be reduced greatly by getting ambulatory surgery centers to do these cases. With that, anything that we can help with, you guys have our information, and we're going to continue to take care of all of you and your family with every opportunity that we get.
Thank you, ladies. I do have a couple of questions. Of your 21 multi-specialty, I would imagine the majority of those are hospital-owned?
You can't be hospital-owned and be an ambulatory surgery center. They may have a piece of one. They may own a piece of one. Now, there are 3 that are, something's going on with some hospitals on the coast. Whether they're actually an ambulatory surgery center anymore or not is the question.
I believe it's, if I had to guess, because I work with a lot of centers through the state on a consultative level, if I had to guess, I'd maybe say 50% have some kind of joint venture. I know like in Laurel there's one, but I work for one on the coast that is fully physician-owned. So I couldn't necessarily tell you it was a majority.
And of those, are they on the hospital campus?
Yeah.
There's a difference in hospital outpatient departments and ambulatory surgery centers, and that's what I was meaning a minute ago. A hospital outpatient department is fully owned by the hospital. An ambulatory surgery center, the physicians will have a shared ownership in that.
But I'm also familiar with some hospitals having ownership in ambulatory surgery centers as well. But you made reference to the patients that you serve or provide services to, and then the hospital. You're mainly, sort of use the word elective, but you're basically dealing with elective type of surgeries, and your patients are probably staying 23-hour OB, or how long are your they being observed after surgery?
I'll say this, in a conversation I made sure we had with Dr. Dobbs in March, just because it's elective did not mean it's not necessary. So yes, they are elective surgeries, and they are, ambulatory surgery is by definition less than 24 hours.
Right, so how long do you typically hold them there?
It depends on the facility. You can have an eye facility that their patients are in and out within an hour. You know, there are rules regarding Medicare that if you're keeping patients in recovery more than 4 hours, you need to be looking at what you're doing and why and doing those cases.
All right, and kind of my last one, during the early stage of COVID, a lot of elective surgeries were encouraged to be postponed till later on. I would imagine that had a significant effect on your operations. Could you talk to us a little bit about that?
Very much so. There are several facilities that closed. People went home. I know in our facility, for example, we take care of a lot of breast cancer patients. So and hand injuries, we do plastic and hand surgery. So with those, we stayed open for those that we needed to take care of. But by far and large, most everybody was sent home. There was a good bit, we had a great deal of conversation about, and I was very relieved to see when Dr. Dobbs opened surgery centers back up for us to be able to work again at the end of April. One of the things that we were really pushing about was, for example, when I opened this up and I was talking about GI associates, just then talking to Dr. Reed Hogan was talking about the number of GI cancers that would be missed, diagnosis would be missed or delayed without ambulatory surgery centers being able to work. So there was a lot of that. We got back in, we took care of our backlog. We're still seeing a higher influx of patients who choose to be done in an ambulatory surgery center. We screen our patients. The levels that we go to, we've always screened our patients to a high level anyway, but as we don't do what's called an anesthesia class 4 patient, so everybody has to be cleared. You have to be able to walk in and able to walk out, exactly. So some of those sicker patients aren't necessarily done in a surgery center. But the levels that we've gone to, the staff that we've added to make sure that we're calling patients ahead of time, the physical barriers that we've added, the amount of supplies that we end up buying, sometimes from, no telling where you're going to have to find a mask. I mean, it's one of those things that we've gone through to make sure to keep our patients safe. We offer testing. All of these things that we've done to be able to continue to take care of our patients.
All right, thank you. And that sort of brings me to the point of earlier question I asked. Part of the shutdown, as my understanding, was so that patients didn't otherwise have to occupy an ICU bed because we're trying to preserve those. But the patients that you're taking and dealing with, as you mentioned, are walking in, walking out, maybe going by a wheelchair or something like that. But
Right.
But your patients aren't ending up in an ICU bed.
Right. We have even in conversations with all of our members, we have made sure that we have stressed patients, even if you had a patient that you might perform surgery on, like for us maybe an I&D of a hand, and it's a really bad hand infection. If they were going to be even the potential of if that physician thought anywhere in his mind that that patient could be admitted, do not do that case in that ambulatory surgery center. Go ahead and put him in the hospital to start with, which is what they should have done. And if there's ever a question on that patient's health in any way that we could delay this, we've done that as well. We make sure, I'm frequently on the phone with our members and keeping up with the numbers and wanting to make sure that we're not admitting patients to the hospital, that we're keeping them out of the hospital. I know just last week I had a patient that wasn't doing as well in recovery. Her SATs weren't up quite as much as they should be, like her to go home, and my recovery room nurses were pushing. Of course, they wanted to go home, so they were pushing, they wanted to send her home. And I'm like, nope, you're going to sit down. We're going to sit here for a little while, we're gonna see if she doesn't get better. She wasn't in any danger, but we were not at a level that we wanted her to go home by herself. So we stayed another couple hours and made sure that she was okay. She went home with my phone number. She called me during the night, and I went to her house and checked on her the next morning. So these are the things that we're making sure that we do, that we don't want to have to send patients to the hospital again. They're by the grace of God. I have to go to one. So they've got their handful. So we want to take care, and we don't want to make sure that we don't impede on them.
Thank you. Senator Harkins.
Thank you. Thank you for being here today. My question is around the first item under your general notes, or the second one actually. 21 of the multi-specialties are CON required facilities, 51 are single specialty CON exempt. So if it's a single specialty, you don't have to have a CON to put in an ambulatory surgical center.
Right, you have to put the application in, and they have to look at your data, and then they deem that you are exempt.
And it's called a letter of non-reviewability.
Okay. Is single specialty limited to that facility, or could it have a facility that several different single specialties would operate in on different days of the week? Or like, you know, if a group owned a surgical care center and they had a single specialty that did their procedures on Monday, had a different one that did something on Wednesday and a different one that did something on Friday, is that CON exempt, or would that be considered a multi-specialty?
Typically, up until this year, if you had a surgery center, and let's say that you're a group of ophthalmologists, and you had another group of ophthalmologists that wanted to use your facility on alternate days, they could do that. They would have to apply for their own. Since each one is considered a extension of their office, they would also have to apply for their own ambulatory surgery, single specialty. They would just be working in that location on different days. Federal government report says that you cannot both of those entities cannot be in the same space at the same time. Up until this year, if you were to have an additional entity work in your facility, it had to be the same specialty up until this year.
So it had to be the same skill, practice, or whatever
Correct.
it is
If
that
it
you
was
have
an ophthalmology single specialty facility, then you could only allow and your physicians, say, worked Monday, Wednesday, Friday, and Group B wanted to work Tuesday, Thursday, then that could happen. The Department of Utilization made a change this year in allowing alternate specialties to work in those facilities again, and that's a federal requirement that they can't be in there at the same time.
So you could have different specialties on different days of the week without a CON?
You have to apply and
Still
get
have
the
to
letter.
apply, but
and
you don't
get
have
the
to get a
letter.
CON.
Yeah, but you could, you have, as long as they're not in there at the same time, you could have five days a week. You could have 10 if they could get in and out of there in a day.
Okay. On the multi-specialty CON required facilities, are they limited to the number of specialties that are allowable?
They're limited as to what is typically allowed in the state. For example, like last year, we just went through the cardiology and created the cardiac ambulatory surgery center. So as long as it is a covered procedure within the state, yes, and all of that data is put into your initial ambulatory surgery center application.
How many different specialties are allowed right now?
Plastic pain.
I mean, I don't even know, like 20, 30, 50?
No, I would say more like 15, 10.
Yeah.
Yeah.
10 to
Anything that
15?
Any specialty that typically does outpatient surgery.
Outpatient surgery.
Orthopedics, GI, pain, ophthalmology, urology,
Ortho.
plastics.
Yeah, think about your
spine.
family, kids, grandparents have had surgery and what they've had, and that anything they went in and went on the same day. I mean,
Okay.
you've got spine, orthopedics, ENT, the gamut. Pain, foot, ophthalmology, everything.
Senator Wiggins.
Thank you. I'm curious. Y'all and the ones before you had good things to say about the managed care organizations. Prior to that, it seemed like others were teeing them up. So what is it that gives, why do y'all have a good relationship with them?
We know where to find them? I don't
We know who they are. Actually, I will say this, just based on the fact that I work a lot with a bunch of different centers, intimately, especially about 4 right now. There's issues. I mean, you know.
Yeah, no, I get that.
But a lot of times people like me, like if you have a normal center where you have somebody who's posting payments every day and getting denials, they're going to have to go through this channel, that channel. I mean, sometimes it's very bureaucratic, but from an administrative level, if you have someone in your center that has the relationships maybe just on the contracting side, I go up the ladder, and I just bark until someone listens, so I'm sort of persnickety. So, and I've taken a long time to build relationships, especially with Magnolia and Molina. UHC is much more difficult, and I didn't go there because I would probably be on the side of negative much more than positive, although we've all had our moments when we all work together. It's just UHC is such a big company, and again, back to my pediatric dental issue, they are non-responsive to my phone calls, emails, or any attempts over the years to try to work together to save money. So, but that's on them because I guess they're managing it.
And some bigger entities may be like that bigger ship that has to turn. It takes them a little more. We're a little more nimble, and although mine and Leah's background are a little different, we both know coding, we both know our facilities.
And we're both
we know
persnickety.
other facilities. Yeah.
But especially Magnolia, because they've been here a long time. I mean, I've met with Aaron Sisk before. I mean, they're just like, I can call people, text them, email them, and I get responses. Molina has come, I mean, I've had mainly good experience with Molina. It was a little bit hard off the bat, but them coming in, and so far, it's personal relationships that they've been willing to build with us. So I have to say, you know, I mean, everyone has their issues, and there is a lot of red tape that we did mention in general, but you know, I just worked through a big issue with Molina, and they came to the table and they gave us a ticket when they didn't have to, and processed some claims for us.
And we're aligned. Everybody's got skin
You're
in the
what?
They
game.
know that we save them money.
Okay, so, which brings me to my next question, which on the handout that you gave to us, you mentioned allow managed care to move cases to ASCs like commercial does. Cases are required to be done in ASC unless otherwise documented as medically required in a hospital. Is that what you're talking about being aligned?
So we do. That's
So what happens
in
on the
Florida.
So what happens on the commercial side?
The commercial, the payers make it much more difficult for now even Medicare is trying to, they're making pre-auth where if you have a carpal tunnel at a surgery center and you're a UHC, you don't have to have pre-authorization. They're making the offices pre-authorize and go through the extra steps now. And they claim on paper that if there is a UHC, by UHC, if there's an ASC that available for the
So
physician.
they're on the commercial side, they're requiring their beneficiaries to go to an ASC unless otherwise noted.
Yeah,
Okay,
they're
the
not
reason-
mandating, but they're
Right.
making it more difficult on the physician side in the offices.
They're mandating it unless you have
Okay.
documentation otherwise.
The reason, and don't let me put words in your mouth, but the reason is because the costs are less in an ASC than in a hospital setting. Is that correct?
Yes, sir.
And you were talking about like this $800, that y'all only get $800, and then they go to the hospital. I mean, you're familiar with what I will call the hidden costs in the hospital model that goes on, that when everybody when people get their bills, they look at them and they're 27 pages long of charges on a hospital bill. Is that right? I mean, you know what I'm talking about.
That hospitals do itemized billing. Surgery center does. You get one bill, it's one code, it's one
You get one
payment,
bill, one code, and you
nothing
do that.
detailed.
Okay.
Whatever's detailed, that's our problem.
So when you say you're aligned, it's because you're trying to, the ASC is designed to deliver care at a managed, affordable cost. Am I correct in saying that?
We have to.
Okay, is that not what, and so when you say you're aligned with a managed care company, is that not what they're supposed to be doing or trying to do?
Yeah, yes.
Okay, so and you mentioned taxpayer, is that not beneficial to the taxpayer?
Yes, sir.
Absolutely.
And you pay taxes, don't you?
Absolutely.
Okay,
Yes.
so, I guess I kind of scratch my head that maybe sometimes we got competing business models here, and the ASC is more of a modern, how long have ASCs been involved, or been in existence?
Since the late 70s.
Okay, so it's relatively new, whereas the hospital models under the Hill-Burton Act have been around for 100 years. Okay, so it's kind of antiquated.
Well, keep in mind what I said too, though. I mean, we don't set ourselves out to compare ourselves directly
I
to
understand.
hospitals. There's a small part of what hospitals do is what we do.
Got it. And yeah, in the hospitals, there's severe patients and things like that that have to be done in the hospital on that. But, okay, you've answered my questions. Thank you very much.
Okay, we have Senator Bryant, and then we have three others. I'm going to ask you to try to make your questions brief, as we do have another presenter. Senator Bryant.
I would say, Mr. Chairman, I think it is unfair for Senator Wiggins to simultaneously lead the witness and then protest that he does not wish to put words in the witness's mouth. I understand he's going to lead all the witnesses, and I accept that, but the protestation that he doesn't want to put words in their mouth really is unfair.
In some courtrooms, that would be called good lawyering.
To what extent is uncompensated care a problem for ambulatory surgical centers?
It's becoming more of a problem every day. That's just, we have by far, we will think we've done everything right. And again, I think I mentioned on the front end with a prior authorization or something like that, there's not an I dotted, there's not a T crossed, we're not going to get paid. And surgeons not going to get paid, we're not going to get paid, we're out. We've still got to pay that nurse, we've still got to pay for those anesthesia products, we've got to pay our rent and utilities. But yes, that's happening more and more.
So I think, as best I can understand from your answer, your problem is for claims which are being denied. That's the problem you're having with uncompensated care.
Yes.
What about charity patients when you know up front that you're not going to get compensated? To what extent is that a problem?
We don't consider that a problem. I think every facility does that in some way, even the ones that are, we frequently will have, I'll get calls from physicians going, what can we do? What can we do? They'll even tell me, some of the doctors will even tell me that they'll pay the cost in the surgery center to be able to do that patient there. I mean, I get that at least a couple times a week in my facility, because like I said, we do breast cancer patients, they've exhausted their insurance, they don't have any other resources, and it's just, they may need a piece, what we call a piece of allograft tissue that may cost us $9,000 for that piece of tissue. And some of my physicians will just say they're gonna pay for it. Mississippians are good about taking care of other people and taking care of their people, so that's what happens.
Well, it would be helpful, I think, because the hospitals always come up and tell us they have this problem with uncompensated care, and I just wondered if maybe when you have a chance, you could sort of come up with some statewide figures about how much uncompensated care is costing the ambulatory surgery centers.
That would be a great thing. We'll definitely, our next year's dues will come due in January, and we're sending out invoices and information now for that, and that'll be part of our request to get that information.
Well, I think the quicker we could get that information, the more helpful it would be. You mentioned a employee with an income of $58,000 that pays $13,000 in taxes at a 22% tax rate. I just wondered where the 22% tax rate came from and what assumptions were being made about the employee, whether the employee is a individual or whether the employee is a member of a household, whether the employee has children, that sort of, can you sort of help me with your assumption?
The 22% number came from one of our accountants that gave us that information. I can't speak to
I'm sorry, I just didn't hear.
I'm sorry? Oh, the 22% came from one of our accountants. You guys would probably know that information better than I would, is what that is. I can just tell you what their median income is. Overall, mostly, ambulatory surgery centers are majorly made up of females. So can't speak to how many of them are necessarily head of household. We do have a good many that are single moms, so, but they're also, it's widely diverse in where they're going to fall in their income, as to whether they're a member of a household or the head of their household.
Well, I'm just simply trying to find out, there's a statement here that says on that $58,000 income at a 22% tax rate, these employees pay just under $13,000 annually in taxes. I accept that 58 times 0.22 equals 13, but apart from that, I'm just wondering what sort of assumptions were made, because the implication is that's a typical amount of taxes paid by the employee, and I'm just not sure if this is income tax or Social Security or federal income tax or state income tax, or that would, it'd be helpful to know what assumptions were made about that.
The point we were trying to make on that is the jobs that ambulatory surgery centers provide, the tax base that they provide, the value to communities and what those jobs offer. Now that $13,000 may not be right, but I don't think they're getting away with not paying anything either. So, and they're also members of their community and they're paying tax in other ways.
Well, I would think that the amount of health care that's provided is going to be provided, the issues where it's provided, but somebody somewhere is going to be providing this health care, and somebody somewhere is going to be getting this $58,000 salary that you mentioned.
I don't know that I'd make that assumptions with many people talking about as many rural hospitals that have closed and care that is not in certain areas, or the fact that we had, I said when I started that we have 72 ambulatory surgery centers and we had almost 118 at least 15 years ago. So I can't say that I would assume that they would be there and that would be provided. I would hope so. I don't know that it would, just because it's there, that it's going to be.
Thank you.
Senator Blunt.
You may not be able to do this because it may vary based on the specialty and the services provided at each AA center, but can you please give me an idea of your payer mix generally, private pay, Medicare, Medicaid, self-pay?
It varies greatly for facility. An ophthalmology facility may be a lot heavier Medicare than perhaps mine would be. You're going to have a difference in orthopedics, ENT.
Rural versus, I have a client in Biloxi that is Medicare, Medicaid is about 35-40%, commercials the rest. Well, and then there's TRICARE and workers' comp that are about less than 5% each. I have a client in Laurel that's about 80% Medicare, Medicaid, because they do eyes and GI, which are typically specialties where you see Medicare and then you see Medicaid. Ear, nose, and throat is another one where you can see a lot of commercial for adults with sinuses, but on the other hand, you'll have children that need tubes or tonsils, and when you say children in this state, there's a significant majority, I don't know the number, that are Medicaid covered. So it really depends on the center.
It's specialty driven primarily?
I'm sorry?
It's specialty driven primarily?
It can be. Eyes definitely, GI definitely, ENT mix. Ortho, you're probably going to get more commercial because orthopedics is more of the age of patients that, 16, you have a better age range of patients that are in the commercial realm. But yes, it depends, sometimes specialty driven.
Representative Curry.
So help me understand something. Let's go to tonsils, you just mentioned that, or tubes. You have a code, and I guess we're talking Medicaid hearing here. So tell me how you're saving us money when you're billing the same code that they would bill in a hospital.
Okay. It's all based, well, that what I know is our ASCs are paid based on the national CMS ASC fee schedule, which is very different from the hospital outpatient HOPD fee schedule. So a patient could go to, for example, UMMC and have a TNA and get billed, and again too, hospitals like UMMC or any of the other hospitals in the state are able to bill differently. They're able to bill several more codes. Sometimes it's medication, implants, and it's the procedure code, obviously. In an ASC, we can't bill for we have special codes we can in certain situations, but for a TNA, one code. So it's just the way that the coding rules are, and the fee schedule for, even though it's an outpatient procedure done at a hospital, which you would see the letters HOPD versus an ASC, are very different. Nationally, we're paid the same codes, different sites of service. There's averages, there's sometimes differences of 50%, 100% lower. I mean, it's very, very, very significant how much lower we're paid. So everything from there trickles down to our fees in this state are based, or our reimbursement is based on the CMS fee schedule, and Medicaid takes a certain percentage of that.
Okay. I'd like some more information on that if you could get it to me.
Yes.
Thank you. And our last question comes from Representative Roberson.
Thank you, ladies, for coming here. I'm fascinated by your business model, and I say that because I can't see why a physician would go and work here and get paid less. I mean, that's the part that blew my mind. Would it be fair to say that if you had to have an emergency room and if you had to have the same things the hospital did, the fee schedule would be different? Is that a fair estimate?
I think that's why the fee schedules are different. But keep in mind, surgeons aren't paid in a hospital outpatient department. They don't get a share, they don't get a distribution. They're not paid.
So you're kind of cutting out the middleman, so to speak, that being the hospital.
Okay, when a surgeon goes to a hospital and performs a TNA, or when they go to the surgery center, they bill for their services as a surgeon. That reimbursement is the same. The facility is what we're talking about, and that's what's different.
Yeah, thank you. Their light bulb just went off. Thank you.
You have a bill for surgery, you'll have a bill for your anesthesia.
It's a pretty dim light bulb, but
touche.
Oh, I don't know how bright it is.
Thank you.
All right. Thank you, ladies. Appreciate the presentation.
And I will say this, any of you are invited to come to any of the ambulatory centers and tour.
Thank you. Next up, we're going to hear from the Nursing Association, Teresa Malone, who's the Executive Director.
Correct. They don't have the same cost. Okay.
Hi, Ms. Malone.
Thank you so much for allowing me to be here today, Mr. Chairman, to the committee. I'm Teresa Malone. I'm the Executive Director of the Mississippi Nurses Association that represents registered nurses and advanced practice registered nurses across all nursing roles in Mississippi. Although I'm providing information today on some of the challenges that nurses face, I want to take this opportunity to recognize and thank Executive Director Drew Snyder and his staff for working with us over the past several years to address many of the issues that our nurses have faced. Likewise, I want to express our commitment and our dedication to continuing to working with Medicaid as well as with the legislature to address some of these additional issues that are currently impacting the efficient and cost-effective care to Medicaid patients. In Mississippi today, there are about 51,000 registered nurses, and there are about 6,600 advanced practice registered nurses. Of those advanced practice registered nurses, about 5,600 are considered nurse practitioners.
And as you know, and especially in our rural areas today, nurse practitioners are providing primary care, but in many areas, they're the only provider that Medicaid patients can see. So they're incredibly important to our Medicaid population. I'm going to be talking to you today primarily about issues that impact those nurse practitioners, some of whom actually own their own clinics in those rural areas. I know this has been a very long day. Some of you that know me know I like to talk, but I'm actually going to be brief today. You have heard from others about the credentialing issues, the issues with prior authorizations and appeals. So I'm going to cover those, but I'm going to cover them very quickly. You've heard about the credentialing issues, the time that it takes, and it's really twofold. In many cases, you'll have a nurse practitioner that's already been hired, and they're waiting to see patients, but unfortunately, because of the time that it takes to go through this credentialing process with 3 organizations, in many cases, they're seeing patients, but they're not able to see Medicaid patients. So if there would be a way to expedite the turnaround time on this, to make the information more transparent so that when information is provided, it could expedite the process, that would definitely improve access to care. It would improve the revenue stream to our nurse practitioners, and it would benefit the Medicaid patients as a whole. Prior authorization and appeals, again, you've heard that, and this impacts nurse practitioners as well. In trying to obtain the best care possible for a patient, and then you have a delay, either from a prior authorization or an appeal, that puts the nurse practitioner and the patient in a difficult situation. For example, if you've already initiated that prior approval or that appeal, and the patient knows that, well, then the patient is under stress because they're waiting on that outcome as well, just like that provider. So if there would be a way to standardize some of that documentation, to make sure that they understand exactly what's going to be, the MCOs put that out there and make sure that the provider understands exactly what's needed up front, hopefully that could circumvent some of these long-standing delays in receiving information back. And in many cases, it can help the patient. The last thing that you want is, in the middle of all this, a patient not to receive care as quickly as possible, and then heaven forbid they end up in an emergency room, because we all know that's the most costly care you can provide. Reimbursement has been discussed. Nurse practitioners face a little bit of a different challenge when it comes to reimbursement. Nurse practitioners in Mississippi are reimbursed at 85% of what physicians are reimbursed for the same services. Take that, couple it with the fact that we've had COVID, and you've heard how that's impacted clinics and it's impacted nurse practitioners as well. And you can see that from a financial standpoint, this can be very disadvantageous to our nurse practitioners in our state. So we would greatly appreciate consideration being given to considering reimbursement rates for nurse practitioners equal to those of physicians that you see today in 27 other states as well as the District of Columbia. And then one of the last items I'm going to mention, although this is not a part of the Medicaid technical bill itself, it definitely impacts Medicaid patients and it impacts providers as well. In Mississippi, nurse practitioners are required to have what's called a collaborative agreement. And in essence, that's a contract with the physician before they can render care. Not only does that frequently increase the cost of doing business to nurse practitioners, but it also impacts a very important aspect in our state today, and that's durable medical equipment. A couple of years ago, CMS dictated that in Mississippi, nurse practitioners could order durable medical equipment, but they had to have a certifying physician as well. Prior to that, nurse practitioners had been ordering DME for years. Well, during those discussions with CMS, and again, I want to thank the Division of Medicaid for allowing us to participate in those with CMS. CMS advised that if Mississippi were a full practice authority state, nurse practitioners would be allowed to write DME orders, and you would not need a physician coming in and certifying those orders. So, as you've heard from so many organizations, those 3 areas are a challenge. I know a question was asked earlier about MCOs and the interaction from providers with MCOs, and I would say that it's great to establish these long-standing relationships. It's great to get to know people at the MCOs, and we want nurse practitioners and nurses to do that. But on a routine basis, you shouldn't really have to jump through a lot of hoops and escalate requests up the ladder. It should be a pretty simple process that everyone understands, with the process in place, with information being disseminated, so that providers can very readily understand exactly what those MCOs need. Many of you have heard me say this in the past. It's been said in different ways today by other presenters, but in Mississippi today, with our need for access to care, with our need for preventive services, for not only the access to, but the encouragement of Medicaid patients to seek care in the most efficient and cost-effective setting, because that's beneficial to Medicaid as well. We really need providers to be rendering care and not trying to traverse and understand and handle what in many cases are burdensome processes. So I believe that I'm actually brief in my comments for once, and I will stop there. If you have any questions, I'll be glad to address them.
Thank you, ma'am. Since you brought it up, and I really didn't want to go here, but what do you do to monitor the scope of practice with nurses? Because that's been a big debate within the scope of, the full practice authority.
Sure, and full practice authority is different from increasing scope of practice. I want to make that clear. Scope of practice is actually monitored by the Mississippi Board of Nursing, and they do that very similar to the medical board. They receive complaints, they have investigators, they go out, they look at nurse practitioners. In addition to that, every insurance company, the Division of Medicaid, are all looking at anomalies that pop up in claim systems. So the full practice authority is not increasing the scope of practice, it is simply dictating that you would no longer have to have what's called a contract or a collaborative agreement, which is a contract, with a physician in order to render care. 21 states and the District of Columbia already have full practice authority.
Chairman Hood? Anybody on the committee, questions? Representative Curry?
Thank you, and thank you for being here. I think you were sick the last time.
I was.
So
I don't think y'all would have wanted me here.
Glad you're doing better. So we keep hearing the same thing, and I agree with you, and I just wanted to make this point. I'm so glad the ladies from ambulatory surgery have connections, but that doesn't mean every clinic, every hospital, all of the healthcare providers throughout the state, we don't have those connections. I don't have one with United. I call their lobbyist, so I'd like to have that. But, it's just this thing to say that's wonderful for them that they're able to do that, but that doesn't help everybody throughout the state. And I thank you for helping nurse practitioners, and hopefully we can make sure this is better.
Senator Wiggins?
Thank you, Mr. Chairman. I wasn't going to go here, but the esteemed chairman opened the door. But you're not saying, so about the scope of practice, you're not saying, nurses don't go to medical school. Nurse practitioners don't go to medical school.
Correct.
They don't do a fellowship in surgery or whatever it is, cardiac, thoracic surgery, or they don't do that. So you're not saying that they should be reimbursed the same amount that let's just say, a orthopedic surgeon does a Medicaid. You're not saying that a nurse practitioner should be reimbursed at the same amount that orthopedic surgeon should.
I'm saying that, for example, if I go in and I see a nurse practitioner, and let's use something really simple. Let's say I have the flu. Then that nurse practitioner is going through the same steps, the same diagnosis as a physician in those instances.
And I'm sorry to interrupt, but you're right, but the doctor, or in the case of a surgeon, is not going to see that patient and diagnose, and that's what their staff is that does that, correct?
Well, I'm saying when it's the same service. For example, the thoracic surgeon is performing surgery. The nurse practitioner is not performing surgery. So I think we have to be really careful on that discussion. So what I'm saying is for those instances where nurse practitioners are rendering the same service in a clinic setting in many cases, and 27 states plus the District of Columbia are currently doing this, that they should receive the same reimbursement for those services as a physician would, especially taking into consideration the fact that, again, nurse practitioners, especially in our rural areas, are primary care for the most part.
I guess what I'm trying to, on that issue, get at is that I don't know that there's a duplication of services going on. And I may be wrong, but I don't know that even a doctor is doing the same thing that the nurse practitioner is in certain situations. I mean, I may be wrong, but are you saying that a lot of that is going on?
I'm not saying there's a duplication of services. I'm saying that as a Medicaid patient, I go see a nurse practitioner in rural Mississippi. That nurse practitioner is not going to be paid the same amount as if I had gone to see a physician who there may not be one in rural Mississippi, for those services that the physician could provide and the nurse practitioner could provide, but I'm going to a nurse practitioner in those cases to receive the same amount, but not have the patient see two providers.
Got you, but that physician then, his or her training and extra medical school and all that then is not being compensated, or it's not worth it. Is that what you're saying?
No, that is not what I'm saying.
So then they shouldn't be paid on the same level.
No. I'm saying that if a nurse practitioner, again, within the scope of their practice, is providing services, they should receive the payment for those services because they're going through the same process. And again, we're not talking about complex surgeries here. We're talking about those instances where I can go to a physician, I can go to a nurse practitioner. And 27 states plus the District of Columbia currently are doing that.
Okay, and then on the agreement, I know, and I've used this example before, I'm an attorney, so I can go into court, but my paralegal is not allowed to go represent somebody in court. So if there's there's things that I'm trained to as a lawyer, and I have to supervise my paralegal. So that's why the agreement is in place, is it not?
There is no supervision. It's a collaborative agreement, so it's not supervising. So what this agreement does, it basically stipulates that you have to have it in place, and then you will have a collaborating physician. And I'll give you an example. I'm a nurse practitioner, and I have an individual come to my clinic, and I have a collaborator that's in a similar practice, right? But I have someone come to my clinic, and after evaluating them, I think, you know what? They may have heart issues. So I'm not going to call my collaborator at that point. I'm going to reach out to another one of my contacts and get my patient to a specialist because they're having an issue with their heart. And the same can be said on so many other situations. So having that collaborative agreement doesn't mean that the nurse practitioner is going to call that collaborator on every patient. The collaborator comes in on a routine basis and looks at charts. That's one of the primary purposes of that.
Well, I think that, and we don't need to get into it now, but I think there's a difference of opinion as to what the purpose that agreement serves. You talk to one side, and they say it's for protecting the patient. You talk to another side, and they describe it like you're saying. So I think, as the chairman said, we get into this debate about scope of practice. I think that that's going to end up in these discussions. But the reality is that that there's different training, and there's different, just like a tax lawyer's got more training than a regular lawyer, and that's the thing. And with that comes more knowledge and more things that you have to look at. So, thank you, Mr. Chairman.
That's asked and answered in court.
Senator Polk.
Thank you, Mr. Chairman. Good afternoon.
Hi.
As you know, I have supported nurses and nurse practitioners on many bills and trying to get some work done and regarding especially the collaborative agreement. But I heard something today that I've not heard in the 9 years that I've been working with your organization, and now it's all of a sudden a money thing. And that I have not heard in 9 years. It's almost now like, well, now we need to be paid as much. I'd always heard if we do the work, we need to be able to be allowed to do it without collaborative agreement, things like that. So this opens up a whole new window to me, that now it's about money, which many things are. My question is this: most nurse practitioners, or many, have the equivalent, I believe, like MUW, their nurse practitioners leave MUW with a master's degree.
Correct.
So are we overpaying our PhD professors at universities when they do the same thing as a master's degree instructor? They teach the same course, but yet that PhD gets twice the money. Are we being unfair to our master's teachers at universities? Should we cut the pay of PhD? I think we're opening a door here that's going to be hard to keep getting through.
Well, and I'll just say that, and this is totally off subject, but I think if you look at, and y'all probably heard about this, the pay for any of the nurses that are at these universities, there's probably a need across the board for some increases there, because they are so important. No matter what level you're at, they are so important to continuing this increase in the nurses that we need in our state. So that's, I guess, another topic. But
that's another topic. But if you increase the master's degree instructor, shouldn't you at the same time increase the PhD instructor? There would still be a disparity between pay. Isn't that right?
Well, I'm just bringing to you some of the issues that our nurse practitioners are facing. And I also want to say this, and y'all are aware of this, especially in our rural areas, nurse practitioners are typically individuals that have lived there, they reside there, they became a registered nurse, and then they realized there was a need in their community for additional access to care. They return to school, they become a nurse practitioner, and they remain in that community. There are a number of nurse practitioners that are opening clinics and have opened clinics where they grew up. So again, when I mentioned that primary care, they really are becoming the backbone of that.
Representative Curry.
Thank you. And I was just, my memory was just taken. Yes, I do have a connection with United, and they texted me and reminded me, so I apologize for that, first of all. And when the nurse practitioner sees a patient in their clinic for the flu, like you were saying, they too, just like the doctors, have nurses and equipment and all of the things that the doctors have to pay for in their offices. When a nurse practitioner sees a patient in their scope of practice, they also are having to pay a large sum of money to a physician just to be able to have the privilege of seeing that patient, some up to $5,000 a month. So they need to be paid up to the correct amount so the physicians can continue to bring in all of their money. So let's don't forget the reason why the physicians do not want this changed is it's a moneymaker for them, and they can keep their thumb on the top of the nurse practitioners. You don't even have to answer the question. I just did for you. Thank you.
Representative Curry, return my serve.
Representative Scott.
Thank you. I'm glad that Teresa is here from the Nurses Association. Teresa, you indicated that there were 51,000 registered nurses in the state.
Yes, ma'am.
Is there a significant need for additional nurses to be trained?
There are, and that's probably a very lengthy conversation that I'm going to try to condense as well. We, like many states, have a significant number of registered nurses and advanced practice registered nurses that could retire. Some definitely within 5 years, a significant number within the next 10 years. Now, when you look at the needs within the state, various parts of the state may see more need for a particular, I don't want to use the word specialty, but specialty is a good word. For example, on nurse practitioners, PMHMPs, psychiatric nurses, there's a great need, as you know, in our state for those. So depending on the location in the state you're looking at, they may have a different need than, say, another part of the state. But yes, there is definitely still a need. And especially, and I've seen this a little bit, especially with COVID, you do have some nurses that are electing at this point in time to go ahead and retire. I don't want to say that it's a mass exodus or anything like that, but you know, when someone is looking at the workforce and looking at what they're going to be doing over the next year to 2 years, and based on their age and number of years that they have, some of them are electing to retire.
Now, Teresa, we look at underserved areas, especially from the census demographic standpoint, and we look at rural areas sometimes differently. If we understanding what we consider as underserved in the state of Mississippi, would you not agree that in those underserved areas, there is a significant need just for registered nurses, not to even think about those that are in the advanced practice?
It sometimes depends on, and I hate to get into this, but it depends on the need. I work with a lot of facilities, and some of those facilities are able to hire and retain registered nurses in some areas, where in other areas it's very difficult.
But in the poorer areas, or what we call underserved areas, wouldn't you agree that that is a tremendous challenge for schools? They
Definitely
have to have
for the schools,
nurses,
yes.
for home health, for hospitals, for ambulatory surgical centers, for every aspect of healthcare where there is nursing needed. In the underserved areas, certainly there's a critical need, right?
There are needs within some of those areas, and again, it can vary depending on the facilities that are there. It can vary depending on, even in some cases, you will have some entities that have come up with very innovative ways to retain nurses. You know, right now, I'm sure you're all aware that if you're a nurse and you're willing to go work with COVID patients, I mean, it is astronomical what someone can make going outside the state of Mississippi. And I really have to commend so many of our nurses for remaining in our state and continuing to serve our patients. And it has resulted in some of our facilities coming up with some innovative options, I guess you could say, to retain nurses. And I think they're to be complimented as well, because right now, the last thing that we need to do is lose any of our registered nurses or our advanced practice registered nurses to other states.
And so if we know that we have a significant need, if we know that within 5 years we're going to have that the registered nurse profession in Mississippi is going to be negatively impacted from retirements, would you not agree that we probably, particularly in the areas where we have underserved folk, that we ought to be looking to expand the training platforms in those areas for practical nursing, registered nursing, and on up the line? Because I don't think that people really realize that nursing is, for women, in particular single women and women who have, you know, their relationships have changed. This is a way that people can go back to school and make a difference in their families. And so, do you think that this legislature should be looking with IHL and the junior colleges and expanding some platform training opportunities, particularly in these underserved areas for practical nurses and registered nurses?
IHL, again, another topic, but IHL, as you know, was very instrumental with their grants and loans that they had in place, and of course now they don't have that. So I don't think anyone at this point in time has definitively said exactly how that's impacted the nursing profession, but it has impacted. I know that from the calls that I receive from individuals that are wanting to go to nursing school, and they are trying to find the resources in order to do that. So yes, definitely for individuals going back to school, they're interested in the nursing profession, but in some cases, it's very difficult for them to find the funds to be able to go back.
And so if we don't have nurses, we can talk about credentialing, PA, reimbursement, collaborative, we can talk about all this stuff, but if we don't have the people, Teresa, to do this work, then we're gonna be in pretty bad shape in 5 years, right?
We definitely need to retain our nurses, and we definitely need to make sure that those that are interested in the nursing profession have some avenues to pursue that.
Thank you so much, because I've introduced a bill to do that for I don't know how many years, and we still have not been able to expand nursing opportunities for, particularly for in the areas where we have underserved, where people can, there's a school there that they can see, or there's a satellite there that they can attend. And to be quite frank and honest with you, I think we all know that. I think everybody that's come in here would agree that if you had people in your communities working in these areas, that would help to improve the healthcare outcomes. I think you would agree with that statement, wouldn't you, Teresa?
Yes, definitely. Okay. And that is the ultimate goal with, I think, all healthcare providers, is improving the healthcare of our Mississippians.
Thank you so much.
Thank you, Ms. Malone. Appreciate your testimony.
Thank you very much.
That'll conclude today's hearing. We'll be back here tomorrow at 9:30, where we will hear from hospice, nursing homes, and the Department of Rehab. Thank you.
You got they took the nursing program from Mississippi Valley State University.